Hello, good evening, BBs. Good evening, everyone. Welcome to our good evening, everyone. I'm Doc DK and welcome to our Obgyn summary lecture and Quizmaster session. So magandang gabi sa inyong lahat. Good evening, Doc Broly.
Good evening, everyone. Good evening, DK. Good evening, Nina. And I think we have Mavi with us. I think si Mavi magbibigay ng Quizmasters natin for today. Okay?
Yes, Doc. Sige, before we start, okay, as usual, we will play muna introduction video, no? Yung mga ating videos na for our students na mag-take ng board exam. So, wait lang guys, I'll share it lang.
I close my eyes and I can see a world that's waiting up for me, that I call my own. Through the dark, through the door, through where no one's been before, but it feels like home. They can say it all sounds crazy. They can say I've lost my mind. I don't care, so call me crazy. We can live in a world that we design. 'Cause every night I lie in bed, the brightest colors fill my head. A million dreams are keeping me awake. Of what the world can be, a vision of the one I see. A million dreams is all it's gonna take. A million dreams for the world we're gonna make.
There's a house we can build, every room inside is filled with things from far away. The special things I compile, each one there to make you smile on a rainy day.
They can say it all sounds crazy. They can say we've lost our minds. I don't care if they call us crazy. Run away to a world that we design. 'Cause every night I lie in bed, the brightest colors fill my head. A million dreams are keeping me awake. I think of what the world could be, a vision of the one I see. A million dreams is all it's gonna take. A million dreams for the world we're gonna make.
However big, however small, let me be part of it all. Share your dreams with me. You may be right, you may be wrong, but say that you'll bring me along to the world you see, to the world I
Close my eyes to see. I close my eyes to see. Every night I lie in bed, the brightest colors fill my head.
A million dreams are keeping me away.
A million dreams, a million dreams. I think of what the world could be, a vision of the one I see. A million dreams is all it's gonna take. A million dreams for the world we're gonna make.
Magtibay ng loob, everyone.
For the world they're gonna make.
Alright. Okay, na-inspire ba kayo doon? O sige, dapat siguro, no? So sige, before we officially start our session, I would like to ask you to join me in prayer. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Dear Lord, we come to you in the spirit of learning and humility and love. We are grateful for this opportunity to be together to learn Obgyn and our summary lecture and Quizmaster session for tonight. We ask that you bless our time together as we help the students learn more about this subject, oh Lord, and I pray that you bless them, that you allow them to pass the medical board exam so that they may become instruments of healing for your people. This we ask in Jesus' name, amen. Father, Son, Holy Spirit, amen. All right, mga BBs ko in Zoom and to those in the portal, as I said, magandang gabi. I'm Doc DK, and of course, I'm gonna introduce our speaker for tonight. Okay, sige, wait lang ha. Kamusta kayo mga Bs? Nakaaral na ba ang mga BBs natin ng OB? Nag-move on na ba kayo ng pedia? Alright, sana, di ba? So for tonight's quiz summary lecture, our lecturer is Dr. Nina Katrina Banzuela. She is a graduate of PLM College of Medicine, had her OB-GYN residency at FEU and RMF, a current fellow of POGS, and of course, our Mother Goose Chancellor and Mentor Chancellor of Top Notch Medical Board Prep. For your OB-GYN Quizmaster session, we have Dr. Manuel S. Vidal Jr., a graduate of BS Biochemistry from the LSU, Rank 2 in the chemistry licensure exam, had his medicine at UP Manila, also had his PhD in MolMed and same University of the Philippines, Manila, and currently a visiting pre-doctoral research fellow at the University of Texas Medical Branch at Galveston, Texas. All right, so sila ang ating makakasama for tonight. Good evening, Doc Broly. Do you have any announcements po?
Good evening, everyone. So I'll be conducting first. Pabaguhin natin yung sequence. Iko-conduct ko na muna yung clarifications, corrections. So everyone, kindly get your handouts, your main handouts, okay? Okay, so first I'd like to apologize for the extensive number of differences between the PowerPoint ng teacher tapos yung handouts ninyo. We gave instructions to all of your teachers, not just for OB, na dapat kung ano yung nandun sa PowerPoint nila, dapat exactly the same yung nandun sa handout. Parehas na parehas dapat. Unfortunately, if you remember, okay, we gave the clinical handouts early, mid-June. So I am OB Pedia Surge. Were given early. Medyo naging OC yung mga teachers niya sa OB. So after even they've submitted na the handout, they're the ones who also wrote the handout, by the way. They decided to still change and modify their PowerPoints. So that's why we had to release the addendum. Okay, I apologize for the frustration it has caused you. It has caused frustration for me also. Napagsabihan ko din yung mga teachers regarding this. Ganito yung sinabi ko na mangyayari for the next batch para hindi na maulit ito. If you will remember my style doon sa Fisho.
Chicken, shots, and
Okay?
mashed
Yung style na ginagawa ko sa Fisho, if you remember kung ano yung nandun sa PowerPoint, it's basically screen caps nung handout, nung Fisho handout. I told the OB team na gusto ko exactly the same yung gagawin nila for the next edition. So kung ano yung PowerPoint nila, it must basically be screen caps ng actual handout na lang. This is to ensure na lapat at parehas yung PowerPoint and the handout itself. Aside from OB, we may ask other subjects to do the same technique. Probably anatomy should do that also. But iba itong problema ng OB Medyo kailangan talagang ayusin. So sabi ko, ang quickest way dyan, okay, na pinaka-efficient is you do my style doon sa Fisho. Okay? I also asked them next time to highlight na, gawin na yung guided highlighting technique natin and naka-bold italicized yung kailangan nila. Naging issue din dito, Doc, bakit merong sinama ninyo yung nakasulat sa blueprints? Tapos sinama din ninyo yung nakasulat sa Williams. Bakit hindi na lang parehas? We have to do that kasi since the pandemic, when it happened in 2020, they started using blueprints a lot. Sometimes even more than Williams. So, ang mindset ko, hindi naman kasi pwedeng ibigay lang natin yung nasa blueprints and completely ignore yung Williams. Kasi kahit ang kailangan nyo sa boards ay blueprints, ang kailangan niyo for actual practice, for residency is actually Williams. And unfortunately, kahit yung mga OB teachers aminado, magkaiba talaga yung mga data na nakasulat sa Williams versus doon sa blueprints. May blueprints na review book, may blueprints din na textbook. So ano yung susundin namin doon pagdating sa boards? So ganito yung general rule. Okay? We will give you both, okay, doon sa handout. But okay, kung papipiliin kayo pagdating sa boards, you choose the values, for example, that we gave na nandun sa blueprints. So blueprints over Williams tayo pagdating sa boards. However, pag natapos yung board exam sa tunay na buhay, pag nag-residency kayo, nag-moonlighting kayo, ang susundin ay ang Williams. Okay, there are maraming differences. You'll be given actually a poster, okay, naka-compiled na lahat ng differences na yon. So, the posters are being finalized. We actually have the posters almost ready na yung sa pharma, yung anatomy na nerves, arteries, and veins, meron na rin. I-release na soon. Okay, final polishing and checking na lang. So one of the posters na pinapa-include ko are the differences ng Williams and blueprints. Okay, along with the percentages and numbers commonly asked or previously asked pagdating sa OB. Okay? So once again, my personal apologies for this. Ayusin natin yung sistema for the next batch. So let me give the corrections now, okay, for your handout, okay? So go to page 4, right lower quadrant, okay? Kindly change the value 11 to 13 weeks, okay, to 11 to 14 weeks. So 11 to 14 weeks yung tama. I'll give you time to write, change it na. Okay, next question. Go to page 5, right lower quadrant, kindly correct. Okay. From 40 minutes, gawin yung 30 minutes itong score 2 dito sa fetal movement. Next. The management of ectopic pregnancy, page 5, right lower quadrant. So, nakalusot to doon sa media team. It shouldn't have happened. Itong layout error na to. Okay, so kindly take note kung paano dapat yung bulleting. Okay? Next. Okay, page 9, left lower quadrant. Doc, why is there a difference in terms of the values given? So, why is there a difference between the handout and the video? It has something to do now with the sources being utilized. The one in the handout is the table derived from the most recent blueprints edition. Okay. Well, the one utilized in your actual lecture, in the video and the PowerPoint, is based on Williams 26th edition, which is based on FIGO 2009. So yung mas bago. So kindly take note, okay, of the changes. Okay. Next. Okay. So this is a typo error regarding dun sa greater than or equal to. So change greater than to greater than equal to. Okay. Page 9, left lower quadrant. Your LS ratio, amniotic lecithin sphingomyelin ratio. Okay, next number. So Bishop scoring, okay, in the handout, more than 8 is favorable. In the video, more than 9 is favorable, less than 4 is unfavorable. In Williams, more than 8 is favorable, less than 6 is unfavorable. Which one will be follow? So follow this one, the one that we have highlighted. Okay, next. Signs of placental separation. Okay, so include this one. Okay, an annotation for additional sign of placental separation, which is Calkin sign, a firmer, more globular fundus. So in blueprints, okay, there are only 3 signs of placental separation. However, some references will include your Calkin sign, which describes a firmer and more globular fundus as another sign of placental separation. Okay? Tatlo lang sa blueprints, in other sources, may pang-apat. Next. Page 15, left upper quadrant. So, Doc, ano ba yung tama talaga regarding this one sa induction of labor? Maximum is 3 doses of 0.5 milligram intravaginal dose for 24 hours. You can use this for a maximum of 2 days, so 6 doses in total. Okay? So, kindly modify your handout. Okay? Your teachers made this modification. Next number. Okay. Confusion with fetal growth patterns and fetal growth restriction. Okay. So actually, this is more of a clarification rather than a question. Go to page 20, left lower quadrant. Okay. According to Dr. Anna Cruz, please do not get confused with phases of fetal growth versus disorders of fetal growth. Fetal growth prior to 20 weeks, primarily hyperplastic. Ito yon, yung mga directions ng mga arrows. Increased cell number, symmetric growth, blah, blah, blah. Then yung isa yung hypertrophic increase in cell size. Okay, next. Hirsutism. Okay, Doc, ba't iba-iba yung mga nakasulat na numbers? Okay, may fine print. Kaya iba doon sa lecture, iba doon sa handout. Okay? Here's what you see. More than 3 used to be the cutoff for Asians in 2018. Philippine data, it's more than 7 for Filipinos in 2019. So, okay, kindly modify, okay, yung yellow box ano natin for the cutoff. So, 3, more than 3 for Asian, but for Filipinos, it is more than 7. Okay? So, iba yung sa Asian, iba yung sa Filipinos. Next. Tubal factors, page 64, left lower quadrant. We have issued a clarification regarding the various percentages utilized in blueprints. So take note of the fine print that I'm going to state here. Okay, these two, bakit may differences though? These are both in blueprints. Regarding these factors, the table above shows data from the WHO task force describing the incidence of causes of female factor infertility. There's another table in blueprints, unfortunately, that describes a study on the contribution of various male and female factors to the incidence of infertility in 2014, which may have different set of values compared to WHO. Okay? So it has something to do with the sources na, kaya may differences. Next. Okay. Page 82, upper quadrant. Okay, we just added a title, may missing title for the table. Management of 60 adnexal masses. Ninya, yes?
I-clarify ko lang tong correction na ito. Ang nasabi ko kasi sa handout, yung naka-highlight na more than 7, yung further imaging of surgical evaluation, if no change, yun kasi yung nasabi ko sa video. Ito yung clarification na yon. So actually, this is further imaging or surgical evaluation if there are changes in the imaging, if there is increase in the size of the mass, or nag-iba yung characteristic niya, dun ka magsa-surgical evaluation. So that's the meaning of this correction. Dun sa nasabi ko. So apologies for that. Mali kasi yung grammar eh. Lifted to from blueprints yung if change. Yun lang yung sinabi niya dun. So mali yung nasabi ko
guys,
sa video.
if positive change. Or if,
Yeah,
if changes are present. Ganun yun na lang.
Yeah.
Word yun na lang siya. Further
Correct.
imaging for surgical evaluation if positive change or if changes are present. Okay. Next. Action of the MPA, page 89, right lower quadrant. Okay. So all progestins, including the MPA, will thicken, not thin, the cervical mucus. So thin ang nakasulat yun sa handout nyo, kindly change to thick. Okay, next. The proper use of COCs, page 90, left lower quadrant. So once again, formatting error. Okay, so kindly fix the leveling of the bullets. Kahit yung ano na lang, observe kung ano yung dapat. Okay. Next. So that's it for the corrections. Let's now go to the clarification. So in this portion, tama yung nakasulit sa handout, but may confusion among the students. So they ask questions directed to the teachers. So hear the answers. Okay, para at least alam ng lahat. Okay. So go to page 1 for the OB scoring. Okay. So Doc, for this one, okay, should the parity score be P2 instead of P1? Okay, so according to Dr. Ana Cruz, this is a screenshot directly from blueprints. In other references for scoring, including blueprints, kapag may TTAL, di na nilalagyan yung parity. So the first one here refers to term, the second one refers to preterm, 2 for miscarriages, and 3 for living. I mentioned this po during the lecture that if based on what we know sa matinong sa atin, for multiple gestation, we add the number of fetuses to all components of TPAL, but it's good to know that in blueprints, they only add it up to the living number. Kasi if blueprints based talaga doon ang exam, then baka yun ang gamitin nila. Okay? So this one, okay, medyo iba dun sa nalalaman nyo based from Williams. So this is based on blueprints. Okay? Actual screen cap. Okay? Next. So why is the abortus count 2 in this scenario? Okay, page 1. Yung may 35-year-old, 2-term pregnancies, etc. Yung, according to Dr. Cruz, yung dalawa po sa abortus is for 1 ectopic and 1 para dun sa nakunan po ako ng isang beses. Kaya naging dalawa yung for, naging 2 yung for abortus. Next. Respiratory system changes, page 2, right upper quadrant. Okay? Yung regarding the total lung capacity. First bullet says the total lung capacity decreases by 5% pregnancy, but the table, okay, says that TLC is unchanged. Okay? Pero may asterisk. Ibig sabihin yan. Okay? From Dr. Nina, during late pregnancy, the subcostal angle increases, as does the anterior, posterior, and transverse diameters of the chest wall and chest wall circumference. These changes compensate for the 4 centimeter elevation of the diaphragm so that the total lung capacity is not significantly reduced. Kaya may asterisk yung TLC sa table na decreased na column. Okay? From Williams, total lung capacity, that's a combination of FRC and IC, is unchanged or decreases by less than 5% at term. So basically, para siyang fine detail kung bakit may differences. Okay? Next. Aneuploidy screening, page 4, right lower quadrant. So what would be the best answer, Doc, for this case? From OB Blueprints, page 37. Okay. 24-year-old, presents with prenatal care, 8 weeks LMP. She has regular menses every 28 to 30 days. We confirm her gestational age with the ultrasound today in the office. No past medical or surgical history. She and her husband of 6 months planned the pregnancy, and they have both been reading about pregnancy and prenatal care. We discussed the prenatal test for the first visit as well as plan throughout the rest of pregnancy. As part of the discussion, you offer her which of the following prenatal screening diagnostic tests. Okay. So traditionally in Top Notch, we do not answer questions that we haven't created. I decided na pagbigyan to kasi naka-base naman talaga sa textbook, review book na ginagamit for the med boards. Okay. At alam mo kung saan galing yung source. Galing talaga siya doon sa textbook review book. So, yan, Dr. Nina answered this. In the US, all pregnant patients are offered this test. Legal kasi ang abortion sa kanila. So if they find out that there are chromosomal abnormalities, there's an option to abort. Kahit invasive procedures have to be offered for them to find out. The correct answer in this one, okay, is E. Okay. Next. On the risk factors for ectopic pregnancy. Okay, page 6, left lower quadrant. It was mentioned that Fitzhugh-Curtis should be noted whenever there is history of pelvic inflammatory disease and ectopic pregnancy. What is its significance? So according to Dr. Ana Cruz, the significance of determining if there is presence of PID in ectopic pregnancy is that you can treat for PID as it can increase the risk for another ectopic pregnancy or unwanted sequelae. In some institutions, the presence of Fitzhugh-Curtis sign during ectopic pregnancy or sometimes even just ectopic pregnancy, they will empirically treat for PID, and this is shown to be the most common risk factor in the general population, although this is not routine practice. Next. Another question on ectopic pregnancy. How does amenorrhea and vaginal bleeding present simultaneously in a triad of ectopic pregnancy? Okay, so Dr. Nia answered this. Amenorrhea because there is pregnancy. Vaginal bleeding is a result of residual breakdown in the uterine cavity due to suboptimal beta-HCG levels. This is only light bleeding. Okay. Next. On abortion, page 7, left upper quadrant. When can we say it's missed abortion versus intrauterine fetal demise if less than 20 weeks AOG? According to Dr. Nina, missed abortion is IUFD prior to 20 weeks. Still IUFD if there was heartbeat detected present prior to the demise. Next. Sample question, okay, G1P0, okay, AOG by LMP came into the vaginal bleeding with no passage of fetal parts. Previous ultrasound done at 9 weeks showed gestational sac with positive yolk sac. An examination, cervix was closed with negative fetal heart tones by Doppler. What is the best management? For the question of best management, early gestations can be evacuated from the uterus by dilation evacuation or with mifepristone and misoprostol in some cases. After 20 weeks, the pregnancy is usually terminated by induction of labor with prostaglandins or high-dose oxytocin. Testmanship will tell you that C could be the correct answer since A and B can be used for earlier gestations. Okay, next. Is evacuation and extraction interchangeable in D&D? Okay. So according to Dr. Ana Cruz, both dilation and evacuation and dilation and extraction are done in second trimester abortions. Dilation and extraction if an intact fetus is removed, but this is usually done only in the United States where abortion is legal. So they are not exactly interchangeable. You may find differences pa rin sila. Next. On recurrent pregnancy loss, page 7, right upper quadrant, is recurrent pregnancy loss defined at 20 weeks or less than 20 weeks AOG. Classical definition, 3 or more consecutive pregnancy losses at less than 20 weeks gestation or with a fetal weight less than 500 grams. Leopold's maneuver in the handout. Leopold's maneuver 3 to check for engagement, 4 to check for cephalic prominence and confirm LM1. In Williams, LM3 to check for engagement and to confirm LM1. LM4 to check for the degree of fetal descent and to check for cephalic prominence. So according to Dr. Nina, okay, Leopold's 1 is fetal lie, Leopold 2, fetal small parts, Leopold 3 is fetal presentation. So depende kung cephalic or breech cephalic, vertex, brow, and face. Breech, sacrum, anterior, posterior. Presentation is noted when the fetus is already engaged. And then Leopold's 4, station or degree of descent. Next. Okay. Rupture of membrane diagnosis, active ROM is not included in the handout under diagnostics but was shown in the video lecture. So according to Dr. Ana Cruz, additional tests for rupture of membrane available nowadays: Amnisure, placental alpha microglobulin 1, active ROM, insulin growth factor binding protein 1, ROM plus IGF BP1 plus alpha fetoprotein. Next, on placental separation, page 14, right upper quadrant. So we've discussed this already earlier. So Calkin sign, in some references, pang-apat, more globular, firmer uterus. Okay? Does 50% of ROM leading to delivery in the 24 hours pertaining to premature rupture of membranes or PPROM? Dr. Ana Cruz, this statement pertains to ROM in general, not just preterm. I think it was put under PPROM lang po, Doc, from the original handouts pa na blueprint space, because this was directly lifted from the blueprint section on PPROM. On oligohydramnios, does the second bullet mean that in the absence of ROM in relation to the presence of already of oligohydramnios, that there will be a 40-fold increase in perinatal mortality, or this means something else? Dr. Ana Cruz, yes, oligohydramnios in the absence of rupture of membranes is associated with a 40-fold increase, 40 times increase in perinatal mortality. GDM diet, there are different values for GDM diet recommended. Which ones should we follow? Okay. Page 29, left lower quadrant. The main text is from the previous handout, that is blueprint space. Iba po ang values na nasa Williams. Usually, sinasama sa Williams ang iba't ibang journal researches. Kaya nag-iiba po ang values minsan. For the exam, go for blueprints. Is the total sugar mentioned referring to baseline sugar levels or GDM glucose targets? Okay, page 29, left lower quadrant. If more than 25 to 30% of the total number of sugars taken during monitoring are elevated than the target levels, you may start insulin therapy. Okay, next. Does the rule of thirds apply to asthma and SLE? Kasi may nakinig doon sa QR code, Doc. Sinabi parang SLE yung rule of thirds. 1/3 improves, 1/3 worsens, 1/3 remains unchanged. Pero nakasulat sa handout natin, nasa yung rule of 1/3 nasa asthma. Does it apply to asthma, SLE, or both? It applies to both asthma and SLE. Yung rule of thirds na yan. Okay, so take note. Rule of thirds applies to both asthma and SLE. On seizures and pregnancy, page 33, left lower quadrant. It was stated that the goal of management is monotherapy with the least teratogenic medications, which are lamotrigine or levetiracetam. However, okay, drug of choice shown in the table is phenytoin. So, according to Dr. Cruz, the table only applies for status epilepticus cases. For seizure control, we still generally follow the rule of ideal monotherapy with the least teratogenic drugs. So take note of this one. This one pertains to the management of patients with STAT-EP. On Turner syndrome, Doc, classically 45XO lang ang Turner syndrome. Bakit meron tayo dito na XXO, Turner syndrome pa rin? Tama po ba to? Tama. 46XX, 46XXO is the mosaic variant of Turner syndrome. Since maternal chromosomes lang ang present at walang galing sa sperm, most probably not both X chromosomes are normal. Okay? When mosaic Turner syndrome occurs, the person usually doesn't have all the associated signs of Turner syndrome. So, hindi lang XO. XXO can also be Turner syndrome. Next, page 57, right lower quadrant. Will the management be the same for both ovarian insufficiency and severe hypothalamic dysfunction? Dr. Nina, before obtaining FSH levels, those with negative progesterone challenge tests are presumed to have low estrogen levels. However, these patients will occasionally respond to Clomid as well. For patients who do not respond to Clomid, human menopausal gonadotropin or recombinant GnRH can be used to simulate ovulation. Both the treatment for negative progesterone challenge depends on the etiology. Okay. Next. Okay, on the handout, it says IVF is offered for women more than 42 years old. In the video, it was said that the first line of treatment for a 42-year-old woman is IVF. So according to Dr. Nina, comprehensive in Compre-Gyne, after 3 to 6 weeks cycles of COS-IUI, IVF should be offered as the next step, and IVF should be the primary therapy in women around age 40. It is clear that in older women, because of reduced efficacy of clomiphene citrate and intrauterine insemination, after age 42, cumulative pregnancy rates over 3 to 9 months are approximately 1.8%. Couples should consider going directly to IVF. Nina?
Yes, parehong galing ng comprehensive gynecology yan 40 years old and 42 years old. Yung 42 years old, yung second paragraph, parang sinabi yun dun sa study. Okay? Yung 40 years old, sinabi yan sa summary, both from Compre-Gyne. So kung tatanungin kayo sa boards, ang isasagot dyan is 40 years old, hindi 42. Okay? Yun lang.
Okay, next. On PCOS and HPO axis, page 62, right lower quadrant, question by the student. In the HPO axis, if there is high concentration of estrogen, it causes positive feedback and LH surge. However, in PCOS, there is no elevated levels of estrogen. There's elevated levels of estrogen, but no LH surge. Why does this happen? Okay, because according to Dr. Nina, in PCOS, there are high levels of estrogen and LH. Okay, no surge because the level of LH is already elevated. Okay. Next, the management of cystic and nexal masses. For reproductive category, okay, more than 7. In the handout, surgical evaluation. If ito, na-mention na nga kanina to. So if changes are present or if there's positive change. Okay. So that's it for the corrections, clarifications. Okay. We've been able to answer all the questions as of, I think, 4 p.m. of today. So kapag may questions pa kayo, ihahabol na lang natin na Dr. Nia and I'll personally give it na lang to you via Facebook. So thank you so much to Dr. Nina, to Dr. Ana Cruz, and to Dr. Mavi. Okay. Again, my apologies for the parang asynchronous nature of your PowerPoint with the handout. We'll make improvements utilizing the visual style ng PowerPoints and handouts by the next batch. Okay, let's go back now to Dr. DK and to my sister, Dr. Nina.
Thank you, Doc Broly, for the corrections and clarifications. Sana nakuha nyo yon mga B, okay? And ito, we'll go to the main part of our program for tonight. Na-introduce ko na po siya kanina. Ayan, sa mga hindi nakakakilala, di ba? Si Dr. Nina Pag hindi siya kilala, grabe naman kayo. Di ba? Dr. Nina, good evening. The virtual floor is yours po.
Thank you so much, Doc DK. Wait lang
Mga B, sa mga BBs ko, if you have questions, okay, dito sa ating Zoom, sa mga nasa portal, please send your questions if ever meron man sa inyong mga mother goose para ma-forward po sa amin. Maraming salamat.
Yes. Thank you, Doc DK. Hello, everyone. So, ako ulit. Sana naaalala niyo ako sa dami ng mga corrections no, at clarifications. Pero good yan. Kasi it means that you really want to learn. No? Hindi lang kayo basta nagbabasa. You really try to understand. So, that is what I really want to impart. No? OB kasi at saka gyne, it's more of understanding kung ano yung mga nangyayari, yung mga processes. No? So, tatry natin yan, i-summarize into 1.5 hours. So, G na ba? G na ba lahat? G na ba ang mga BB ni Doc DK? Walang mahiyain sila. Alright. Excuse me. So, we'll start with obstetrics. So, this is our topic outline. So, you guys just have to listen, Listen lang. If you want to take down notes, no? Pwede naman, no? Pero mas gusto ko na makikinig kayo kung ano ang mga nangyayari. Alright? So, we'll have with obstetrics first. Let's start with prenatal care. So, the initial visit, of course, between 6 and 10 weeks. The history is very important. Okay, G po. The history is very important. No, you have to know the LMP. If the patient has symptoms, the obstetrical history. This what makes us different from mga IM. No, yung obstetric history should be complete. Okay, pero syempre kailangan din ng medical, surgical, family, and social history. And of course, your physical examination. Ang physical examination, no, you have to pay particular importance to the pelvic exam, okay, which includes pap smear, 'di ba? Sa cervical ay sa prenatal evaluation natin, kailangan ng pap smear. Sa guidelines, okay, kung susundin natin yung dating guidelines on pap smear of cytology, kailangan yan 21 years old. Pero pag pregnant, no, nakasulat kasi doon sa first trimester, kailangan mag-pap smear tayo. So regardless sa age. Okay, yung new guidelines for cervical screenings, cervical cytology is 25 years old. Pero ang ginagamit pa rin nila sa board exams is 21 years old. Alright? And ginagamit pa rin sa clinic 21 years old. Also, during prenatal visits, blood pressure, weight, urine dipstick, and measurement of the uterus and auscultation of the fetal heart tones. Every prenatal visit. Bakit nag-urine dipstick? Bakit pala may blood pressure, no? Because your blood pressure, remember, it decreases during the first and second trimester and then slowly returns to baseline during the third trimester. Okay, elevation of the blood pressure may be a sign of preeclampsia. Okay, the maternal weight is followed serially throughout the pregnancy, no, as proxy for adequate nutrition. Also, large weight gain toward the end of the pregnancy can be sign of fluid retention. And syempre, pag fluid retention may edema, pwede rin eclampsia, pre-eclampsia yon. Okay? And then urine dipstick, bakit importante ang urine dipstick, no? It can, pag may protein, pwedeng may pre-eclampsia. Glucose may mean there's diabetes. Pag leukocyte esterase, pwedeng UTI. Okay? And then measurement of the uterus also by the fundic height. Okay? Yung fundic height is measured in centimeters and corresponds roughly to the weeks of gestation. Wala to sa Williams, wala to sa blueprints kung anong age of gestation. Pero ginagamit natin yan at 20 to 36 weeks. Kasi by 36 weeks, hindi na siya nagko-correspond sa age of gestation. Kasi there's what the phenomenon we call lightening, so bumababa na siya, no? So hindi na siya pareho with the fundic height. Anong ibig sabihin nito, Doc? Ang ibig sabihin nito, at 20 weeks, measure mo yung fundic height. Pag measure mo sa fundic height, dapat 20 plus minus 2. Okay? 20 plus minus 2. So ibig sabihin, kung 20 weeks siya, pwedeng ang fundic height niya is 18 to 22. So normal pa yon. Yun yung ibig sabihin niyan, na corresponds roughly to the age of gestation. Again, fundic height plus minus 2 equals your AOG. Okay? And of course, you have to auscultate for the FHT. Okay? Kailan ba tayo nag-auscultate ng FHT? Okay. Pag 6 weeks, hindi mo pwedeng ma-auscultate ang FHT. Okay? We have to use a transvaginal ultrasound. 6 weeks. Present na ang heartbeat niyan supposedly. Dapat. Pag Doppler, yung handheld Doppler, 10 weeks. Pag stethoscope, 20 weeks. Okay? That's the auscultation for FHT. So kung halimbawa, no, wala kayong Doppler, huwag niyong expect na maririnig nyo ang FHT by 16 weeks using your stethoscope. Okay? So 20 weeks pa tayo nagsistep. How about schedule for prenatal visits? Ang schedule natin dyan, every 4 weeks until 28 weeks, every 2 to 3 weeks, 28 weeks to 36 weeks, and then pag pa-term na, weekly na ang prenatal visit. This is for low-risk patients. And then routine tests in prenatal care. So ito yung mga initial and first trimester na tests na kailangan nating i-request. Remember, look at this, urinalysis and culture. So saan to galing? Galing to ng blueprints. Okay? Pag nakita niyo dyan, pag may urinalysis, blueprints yon. If you look at Williams, no, wala nang urinalysis doon. Culture lang, urine culture. Kung hindi available ang urine culture, you request for urine gram stain. So may mga clues, no? Kung saan nila nakuha yung mga tanong. Okay? May mga clues kasi may differences talaga ang Williams at saka ang blueprints. So itong lahat, initial visit and first trimester, may urine, pag nakikita kayong urinalysis, galing yan ng blueprints. Okay? Next, meron dito, yung sinabi ni Doc Broly kanina, early screening for aneuploidy is the nuchal translucency. That's NT plus your serum markers, your HCG, your PAPP. Okay? So yan yung 11 to 14 weeks. This is for your first trimester aneuploidy screening. Okay? So itong tatlong to, mini-measure siya during 11 to 14 weeks. Aneuploidy. Ano bang mga tinetest doon? Diba? Mga chromosomal abnormalities. Okay. So yung measurement ng nuchal translucency by ultrasound, pag more than 3, no, there's a high probability that there is a chromosomal problem. Okay? Now, for the second trimester naman, you have your MSAFP, your triple or your quad screen. Okay, later we'll discuss this. And then your obstetric ultrasound, which is your screening ultrasound, level 1. Screening ultrasound. Okay? Level 1. Ang level 2 kasi, yan yung mga congenital defects. Yun yung congenital anomaly scan, if you've heard of it. Yun yung level 2 na ultrasound. Okay? Pag level 1, screening ultrasound lang. Okay? Biometry. Okay? And then amniocentesis for prenatal diagnosis. Okay? Third trimester, ulitin ng hematocrit, ulitin ng RPRB-DRL, and your GLT. This came from blueprints. No, GLT is 50 grams. 50 grams GTT. Tama ba? Yes, 50 grams. And then GBS culture, we do this at 35 to 37 weeks. At approximately 36 weeks yan ginagawa. Okay? Now, second trimester screening. Ang GLT ginagawa yung 24 to 28 weeks. So your second trimester screening naman is performed between 15 and 21 weeks with your quadruple screen. Ito ginagawa at 15 to 21 weeks. Ang triple screen natin is maternal serum AFP, your MSAFP, your beta HCG, your estriol. Pag sinamahan mo ng inhibin, that is your triple screen. So ano ngayon ang significance nitong quadruple screen? Okay, sa US, guys, ginagawa to, no, ino-offer talaga to sa lahat ng mga pregnant women kasi they have the, sabi nga ni Doc Broly, they have the option to abort. No? So kung may abnormalities dito, they can have it aborted. Sa Pilipinas, hindi natin to ino-offer kasi ang mga magagawa lang nito is to prepare the mother, no? Pero hindi naman tayo pwedeng mag-abort. Okay? So ang ibig sabihin yan, pag may chromosomal anomalies, no? Itong mga to, trisomy 21, trisomy 18, and trisomy 13. Ano ang trisomy 21? This is Down syndrome, 'di ba? So pag Down syndrome, ang AFP mo is decreased, ang beta HCG mo is elevated, ang estriol mo is decreased, ang inhibin mo is elevated. Dok, ang hirap tandaan, Dok. I-alphabetical mo, B. I-alphabetical mo, AFP, beta HCG, estriol, inhibin. 'Di ba? Pag Down syndrome, dahil down muna. Decrease, increase, decrease, increase. Okay? So yan yung Down syndrome. Next, ang Edwards syndrome, lahat naman yan decrease. Ano ang Edwards syndrome? This is trisomy 18. 18, pwede ka na bang bumoto ng 18? E-election. Edward, trisomy 18. Okay? Ang trisomy 13, this is pataw. So it really depends on the defect sa pataw. Okay? So sa pataw syndrome, trisomy 13, parang pre-puberty 13. Okay? Kasi baka nalito tayo sa Edwards at saka sa pataw. So yun yung mga mnemonic doon. Dak masyadong mahilig sa mnemonic, guys. So patawarin nyo ako. Minimemorize talaga lahat yan. Okay. Yun na nga, iba-iba. May clarification kasi dito, no? Measurement of the uterus between 20 and 34 weeks. Yes, pwede rin yon. May ibang sources lang na sinasabi 36 weeks kasi nagbibigay na yung lightening, no? Pero ang ano talaga is 20 to 34. Pwede rin siya hanggang 36. Pero pag tinanong kayo sa exam, pwede hanggang 34. No? Kung 34 at 36 yung nandun, kung ako, 36 yung isasagot ko. Okay? 36. Kasi mas maraming sources. Wala yan sa Williams, wala rin yan sa blueprints. Nanap ko na. Okay? So CPG yan, 20 to 34 weeks, tsaka 36 weeks. O yan, ito yung sinasabi ko kanina, no? Yung level of ultrasound, yung obstetric ultrasound natin. Level 1 is the screening ultrasound, or it is used to document a single ton viable gestation. This is a rudimentary anatomy scan. Pag level 2, this is detailed or targeted, your congenital anomaly scan. It will look at the fetal limbs, identify the sex, show the face, provide extensive views of the heart. Okay, this is used for patients who are at risk for congenital anomalies or have had an abnormal level 1 scan. Okay. Okay. Again, this is your second trimester. Your MSAFP, triple or quad screen is at 15 to 18 weeks. Your obstetric ultrasound screening, rudimentary, it's 18 to 20 weeks. For ultrasound also, you have to check the presentation at 35 to 36 weeks. If breech, you can offer external cephalic version at 37 to 38 weeks. Alam niyo ba external cephalic version? External, labas, cephalic. I-form mo siya into cephalic. No? If breech, ikot mo siya na maging cephalic. Although I haven't done this, no, sa mga sources lang natin yan, no, na pwede kang mag-external cephalic version. Pero dapat meron kang setup for cesarean delivery. Kasi pag na-rupture mo yung bow, i-deliver mo na yan. Kaya ang breech is offered at 37 to 38 weeks para term. Okay? Kaya if na-rupture mo yung bow, TS na siya diretsyo. Okay? Now, itong values na to is from blueprints. Maraming values tungkol sa GDM ang ipepresent natin later. Pero suffice to say na ito ang nasa blueprints. Okay? Ang blueprints, mag-50 grams GLP ka muna. If elevated ng more than 140 milligrams per DL ang GLP, you then proceed to 100 grams GTT. Okay? 2 or more to diagnose as GDM. Pag ang FBS mo 95, 180, 155, and 140. Again, this is from blueprints. Later, we will present yung mga iba pang values. Okay? Pero kung ako, ito talaga yung i-memorize ko yung nasa blueprints. Okay? So that's for prenatal care. Let's now go to fetal lie, posture, presentation, and position. Dito tayo medyo nalilito, no? Kung ano bang ginagawa natin sa Leopold's maneuver. Okay, so fetal lie. Okay, what is fetal lie? Fetal lie is the relationship of the longitudinal axis of the mother to the longitudinal axis of the fetus. Okay, so may dalawa lang, actually tatlo. May tatlong klaseng lie. Okay, you have longitudinal lie, you have oblique lie, and a transverse lie. Okay, so yun yung mga lie. Yung cephalic at saka breech, those are longitudinal lie. Okay. Sige, sa mga babies ko dyan, saglit lang sa mga tanong nyo mga biya, pasensya na. Alright. So sinasabi yung sa GBS daw kanina, 35 to 37 weeks was previous, pero ngayon 36 weeks to 37 weeks. Pwede naman, 36 weeks. Okay? Next. So yung fetal lie mo, again, dalawa yon, longitudinal and transverse. Oblique lie, very unstable lie yon. Magko-convert yon to either longitudinal or transverse lie. Okay? Ngayon may question ako, transverse lie, di ba? Oh. What if ganito yung position ng baby? This is called a back down transverse lie. How will you deliver at back down transverse lie? Will you go vaginal? Will you go CS? Kung CS, what kind of CS? Meron bang may alam dito sa ating Zoom? What kind of delivery pag back down transverse lie? Classical, very good. Classical, may sumagot ng classical CS. You know why it's classical? Pag transverse lie kasi, no, you have to do classical cesarean section. Ano ba ang pag-cut sa classical cesarean section? Kung wari. Ayan. Pag low transverse, okay, di ba yun yung common na ginagawa natin? Low transverse cesarean section. Low transverse, dito ka sa lower uterine segment magka-cut. Kaya siya low transverse. Okay? Pag classical section, no? Pag classical section, dito ka magka-cut sa body na longitudinal. Ganyan ang classical section. Okay? Bakit hindi pwede na low transverse? Hindi pwedeng low transverse kasi delivering a fetus in transverse lie, you need to convert it into breech. Sorry, you need to deliver it as if it were breech. Pag breech delivery, di ba, una yung paa. Kukunin mo yung paa, alright? Tapos saka mo i-deliver, last yung head. Pag ganito yung cut mo sa uterus, wala kang access sa paa. Alright? You will have no access sa paa. Pero pag classical section, okay, you can grasp the fetal feet. You can grasp the feet and deliver, okay, the baby as if it were breech. Okay, sa lahat ng transverse lie, breech delivery talaga ang ginagawa. Okay? Kasi nga you have to grasp the feet. So pag back down, ibig sabihin, back down, yung likod niya, okay, nasa baba. Okay? It is malapit siya sa birth canal. Ganyan. Back down. Kaya ganun yon. Kaya classical cesarean section. Okay? So that's fetal lie. Kung ano lang yung mga relationship of the longitudinal axis of the mother to the fetus. Next, let's go to posture or attitude. Okay. Ito yung mga sinasabi nyo sa mga kaibigan nyo na nag-e-emote. Ano sinasabi nyo? Ay nako, naka-fetal position ka na naman. Hindi yun fetal position. That is actually fetal posture or attitude. So pag malungkot sila, naka-fetal posture sila, no? Sabihin nyo, uma-attitude ka na naman. Lalong malulungkot yon. Okay? Wait lang may question dito. Doc, paano po yung delivery if back up yung fetal lie? You deliver it ng low segment. Pwede siya, basta available ang low segment. No? You deliver it by low segment cesarean section. Okay. Wait lang. Alright. So ito yung fetal posture or fetal attitude. Yung itsura ng mga friends nyo na malungkot. Okay? The fetus forms an ovoid mass that corresponds roughly to the shape of the uterine cavity. The fetus becomes folded upon itself to create a convex back. Yun yung mga itsura nila. The head is sharply flexed. Tandaan nyo, the head is sharply flexed, that the chin is almost in contact with the chest. Nakaganon, di ba? Nakayuko. The thighs are flexed over the abdomen and the legs are bent at the knees. The arms usually is found across the thorax or parallel to the sides, and the umbilical cord fills the space between the extremities. So this is the correct posture and correct attitude. However, may mga variations yan. Okay? We have the vertex, the sinciput, the brow, and the face. Vertex, no, yung nakabend, tapos yung forehead niya, nakabend siya, nakaganyan. Yun yung fetal yun yung normal na fetal attitude. Itong sinciput, diretso siya. Okay? Hindi siya naka-flex, hindi siya naka-extend. In one of the board exams, no, tinanong to, pero hindi sinciput yung ginamit niya na term. Military position, yun pa nga yung sabi eh. Pero it's actually military, hindi fetal presentation to, sorry. Fetal attitude. Sinciput is military attitude. Nakaganyan. Diretso lang. Okay. Brow, slightly extended. Face, hyperextended. Okay. So, yan yung mga fetal attitude natin siya. Okay. Ito yung pinaka nahihirapan din tayo, no? Di ba? Hindi siya sorry, hindi meron kasing animation, hindi siya nag-animation. 'Di ba? This is yung mga anteroposterior diameter of the head. Okay? Important that we know this anteroposterior diameter because ito yung lalabas, 'di ba? Ito yung lalabas sa birth canal. Okay? So kailangan matraverse niya. Alin? Yung inlet, yung midplane, yung outlet. Okay? Yung inlet mo, ang measurement lang niya ng ischial spines, okay, is around 10.5 to 11 cms. So kung mas malaki yung head, yung diameter ng head na papasok, hindi yan ma-engage, hindi yan lalabas. Okay? So that is dystocia because of the dystocia because of the passenger. Okay? So, kailangan nating malaman kung anong ba yung mga diameters ng head na dapat na pumasok, no? Dapat na pumasok sa pelvic inlet. Alright? So, ano ba yung mga yan? Remember, meron kang diameter. Ito, memorize natin to. Meron tayong diameters measuring 9.5 cms. Ito yung diameter na pwedeng makalusot sa inlet. This is the suboccipitobregmatic. Okay, suboccipito. Nasa na ito? Occipital, baba. Suboccipitobregma. This is the bregma. Diba? Ang bregma is yung gitna ng anterior fontanelle. Suboccipitobregmatic, that is 9.5 cms. And ang presentation niya na lalabas is vertex. So, kaya yang lumusot. Suboccipitobregmatic. Now, merong this is submentobregmatic naman, mentum, chin, sa ilalim ng chin. Submentobregmatic. Pag submentobregmatic, that is also 9.5 cms. But it is the face that is presenting. Okay? Doc, bakit hindi lulusot to kahit 9.5 naman siya? Remember, you need to extend a little. No? You need to extend a little yung head para siya makalusot ng inlet. Kung wala nang i-extend ang face. kasi it's hyperextended. So kahit 9.5 siya, hindi na siya maka-extend, hindi siya lulusot. Okay? Hindi siya lulusot. And then, no, may isa. These are the anteroposterior diameter, 18. Another 9.5 na diameter is your biparietal. Biparietal naman is a transverse diameter. Okay, transverse diameter. So balik rin natin to. Ayan, yan siya. So this one, submento-bregmatic, face ang magpapresent. So ito yan. This is 9.5 cms, pero hindi yan lulusot. See, it's hyperextended already. The neck, hyperextended. Diba? Kahit kayo man yan. Diba? Isipin nyo minsan, kung kayo man yan, hindi nyo na kayang lumusot. Bigay na yung ulo nyo. Okay? Bigay na siya. Next, sabi, this one, ito naman yan, suboccipito, bregmatic. Oh, ang lulusot, itong part na to, vertex. This is the vertex. Okay, yan, kaya niyang lumusot. Okay, kasi 9.5 cms. Alright. Question so far from the floor. Oh, sige. Next, tingnan ulit natin yung ibang diameter ng anteroposterior diameter ng head ng baby. You have your suboccipito frontal and then your occipito frontal. Pareho silang frontal. Okay, pero yung isa sa gitna ng forehead, yung suboccipito frontal sa gitna ng forehead, yung occipito frontal sa may eyebrows. Hindi ako yung gumawa nito. Sila, term nila talaga to. Parehong frontal lang. Okay? So your suboccipito, occipital sa ilalim, suboccipito frontal, it's 10 cm. So vertex position yan. So pwede yung lumusot. Okay? Yung occipito frontal, okay, that is a brow presentation. So depende, no? Depende pa rin siya kung kaya niyang lumusot. May mga pwede namang lumulusot, no, pero merong hindi. Okay? Ang pinakamahaba is your mento vertical. This is around 13 to 14 cms, depende kung anong tinitingnan nating sources, no? Pero let's put it at 13 cms. Kasi either naman masyado siyang mahaba, no? Masyado siyang mahaba para lumusot. So mento vertical papuntang vertex. Okay, this is the brow presentation. Sorry, ito palang occipito frontal is also vertex, pero yung mento vertical, this is the brow presentation. Tingnan nyo, paglalabas siya, ganito. Itong yellow. Paglalabas siya, una yung brow. So ito yan, occipito-mental. No? May hirapan din yan kasi sobrang haba, no? Sobrang hindi naman diameter eh. So sobrang haba, no? Nang kailangan pumasok sa birth canal. So yun yung mga diameters natin. Okay, of the fetal head. Okay? So kailangan yung malaman dyan, face. Okay? Brow, vertex presentation. Pag vertex yon, pwedeng lumusot yun. Another type of fetal presentation is breech. You can have frank, complete, or incomplete. Pag frank breech, okay, the knees are flexed, but the hips are flexed, but the knees are extended. Pag complete, flex ang hips, flex ang legs. Pag footling or incomplete, no, or incomplete breech, may isa na nakalusot sa birth canal. Okay? So that is fetal presentation. Again, your fetal presentation can be cephalic, breech. Okay? Ang transverse kasi walang nagpe-present na part. Fetal positions naman, this is the pag cephalic, occiput. Ano yung occiput? That is the posterior fontanelle. Triangular shape, this one. No, yan yung marker natin, yan ang origin natin. the occiput. Pag face, mentum. Okay? Pag face yung presentation, ang position niya dictated by the chin, by the mentum. Pag breech, ang presentation niya sacrum. Pag shoulder, acromion, no? Pero hindi naman talaga nagpe-present 'yon. Parang for the for the chika, sabi ni Williams, no? So it's important to know here that pag mentum posterior, automatic you deliver via cesarean section. Pag mentum anterior, okay, pwede mo siyang i-deliver, no? Pwede kang mag-try ng vaginal delivery. Pero pag mentum posterior, you deliver via, parang mali. Hindi, tama pala. Tama. Pag mentum anterior, pwede mo siyang vaginal delivery. Pero pag posterior, deliver via cesarean section. Okay? So ito yung mga for the cephalic positions. You can have occiput na anterior. Ibig sabihin, yung occiput mo is at the level of the symphysis pubis. Nasa anterior ng mother. So, occiput anterior. This one is right occiput transverse. Nasa right ng mother, pero transverse. This is right occiput anterior. This is right occiput posterior. This is occiput posterior. This is left occiput posterior, left occiput transverse, and left occiput anterior. So, in relation din yan sa maternal pelvis. Okay? Kung anterior, kung transverse, or posterior. Okay? So, naintindihan na natin ang fetal lie, posture, presentation, and position. Okay? Now, let's go to fetal cardiotochogram monitoring. So, ano ba to? Nakita niyo na to? Nung intern kayo? So, this is a blank CTG strip. No? This is a blank CTG strip. Yung nasa taas is your fetal heart rate. Yung nasa baba are your contractions. Fetal heart rate, one small box like this is 10 beats. Yung 1 cm niya is 1 minute. Okay? Yung 1 cm is 1 minute. Meron yan mga 3 cms per minute, pero maganda rin yung 1 cm per minute. Okay? Nan talaga yung basa dyan, 1 cm per minute. So what are the components of your CTG? So you have your baseline fetal heart rate. Ito ang pinaka-importante. No? Ito ang pinakauna, the baseline fetal heart rate. The baseline fetal heart rate is the most occurring fetal heart rate in 10 minutes reported in increments of 5. The normal fetal heart rate is 110 to 160 beats per minute. That's normal. Pag greater than 160 beats per minute, that is fetal tachycardia. Pag less than 110 beats per minute, that is fetal bradycardia. So, can someone tell me sa mga nasa Zoom kung ano ang baseline may sagot na pala. So, the baseline fetal heart rate for this tracing. So, titingnan nyo lang. 120, tapos 120, may ito mataas, 130. Reported siya in increments of 5. So, the baseline fetal heart rate is 120 to 125 beats per minute. That's how it is reported. Okay. The next component is variability. So variability are fluctuations in the fetal heart rate that are irregular in amplitude and frequency. Okay. Actually, it's just a beat-to-beat variability. Okay. Beat-to-beat variability. Parang 120, 130, 135, 122. Ganyan. Okay. So those are the variability, beat-to-beat. Ang sinasabi, variability is your greatest sign of fetal well-being. So kung maganda ang variability, okay yung baby, maganda yung fetal well-being niya. So that's variability. So there are 4 types of variability. You have absent, parang straight line na ganyan, walang fluctuations. You have minimal, less than 5, ganyan-ganyan lang. You have moderate or average, no? Ganyan. And mark, more than 25. Okay, ganyan. Ganyan ang variability. Okay, can someone tell me sa nasa Zoom natin, no, sa chat box, kung what type of variability is this one? Very good. This is minimal variability. 'Di ba? Hindi maganda yung fluctuations niya. How about this one? How about this one? Moderate. Very good. So this is moderate variability. This is normal. How about this one? This is marked variability. Okay, very good kayo na nasa Zoom. Alam ko sumasagot din ng mga nasa portal. Very good kayo dyan. Kung marked variability ito, what is the baseline fetal heart tones? Baseline fetal heart rate, kung bakit nyo nasabing marked variability ito. May makakasagot ba sa floor? Sa mga BBs ko, may makakasagot ba? What's the baseline fetal heart tone? Okay, actually, sa sobrang mark ng variability, very good. May nakasagot, walang baseline fetal heart tone to. 'Di ba? Based on definition, walang baseline to. So pag wala siyang baseline, okay, pag wala siyang baseline or the baseline cannot be determined, it's marked variability, no? Now, let's go to accelerations and decelerations. So accelerations are abrupt increase in FHR. Diba? Abrupt increase in the FHR. Ano ba to? Ito, this one, ito pa. So these are accelerations. Are you familiar with the 215, 15, 20 NST result? 215, 15, 20. Familiar kayo dyan? Pwede naman pala ako mag-Apple Pencil. 2, 15, 15, 20. This is the NST result. Pag reactive, di ba? Reactive ang NST mo, you have a 2, 15, 15, 20. This means you have two accelerations lasting for 15 seconds, 15 beats above your baseline in a 20-minute strip. So reactive NST. Okay? Itong 15-15, that is your definition of an acceleration. Okay? An acceleration is an abrupt increase in the baseline lasting for at least 15 seconds, so 15 to 30 seconds, 15 beats above your baseline, no? So these are accelerations. Yan yung meaning ng acceleration. Okay? So yan yung mga accelerations natin. Pwede rin ang 210, 10, 20. This is also reactive NST for fetuses less than 32 weeks. Okay, so two accelerations, 10 beats above baseline, lasting for at least 10 seconds in a 20-minute strip. Okay, so pag less than 32 weeks, ito yung values natin for reactive NST. All right. Next. So clear na tayo with acceleration. Let's now go to decelerations. For decelerations naman, kabaliktaran ng acceleration. No? We have pababa naman siya. There are decrease in the baseline and can be categorized into three. So yung three natin, you have variable, early, and late. Okay? These are named based on their relationship with the timing of the contractions. See? Mga contractions, ganyan. Basically, decelerations are just decrease in the baseline heart rate. So we have variable deceleration. No? Yung variable deceleration, these are visually apparent abrupt decrease in the FHR. The onset of the deceleration to nadir is less than 30 seconds. And the deceleration lasts more than 15 seconds and less than 2 minutes. So parang kabaliktaran siya ng acceleration. Okay? Wala siyang kinalaman sa fetal heart ay sa contraction. Kung kailan niya gusto mag-appear, dun siya mag-a-appear. Anong ibig sabihin na tong variable deceleration? Pag may variable deceleration, what does this denote? You have Chord compression, very good. Pag chord compression, pathologic, non-pathologic. Pag chord compression, pathologic, non-pathologic. Depende, no? If tuloy-tuloy siya, that is pathologic already. Pero pag hindi, pag isa lang naman, natatakan lang niya yung chord niya, tapos nakalimutan niyang huminga, no? Pag lang, can be non-pathologic. Pero pag dire-diretso, no, pwedeng may nangyayari na sa chord because it's chord compression. Now, these are early decelerations naman. Early decelerations, the onset, nadir, and recovery of the deceleration are coincident with the beginning, peak, and ending of the contraction. So, mirror image siya. Huwag niyo ako i-judge, ako nag-drawing yan. Okay? Yung onset, okay, nadir, and recovery coincides with the beginning, peak, and ending of the contraction. So, what this is the note? Head compression, pathologic, non-pathologic? Non-pathologic. So kung meron kang ganito sa ER, anong gagawin mo? Nakita mo yung patient? What will you do? Wala do, kantahan mo. This is non-pathologic. What will you do? IE mo yan, D. Kasi baka mamaya, di ba, yung head, nako-compress na ng bony prominences, no? Ibig sabihin, malapit na siyang lumabas. Okay? So, yung IE, kasi baka fully na siya at andyan na yung baby. Okay? Huwag tayong ma-RR. Late decelerations, on the other hand, okay, the deceleration is delayed in timing with the nadir, okay? The nadir of the deceleration occurring after the peak of the contraction. Okay? The onset, nadir, and recovery occur after the beginning, peak, and ending of the contraction, respectively. Okay. So, pag late deceleration, anong ibig sabihin nito? Uteroplacental insufficiency. Very good. Pathologic, non-pathologic? Pathologic. Always pathologic. Okay. How about this one? These are late deceleration. These are prolonged deceleration. Diba? Prolonged deceleration, ano bang definition natin ng deceleration? Diba? 2 minutes, pinakamatagal. Pag prolonged deceleration, more than 2 minutes but less than 10 minutes. Kasi pag more than 10 minutes na siya, it's actually just a change in the baseline. Okay? So change in the baseline. Prolonged deceleration is more than 2 minutes but less than 10 minutes. So paano natin babasahin yan, Doc? So we have a 3-tier classification system. Okay, 3-tier classification system. You have your category 1, which is normal. Category 2, which is indeterminate. Dito tayo nagre-resuscitate. And category 3, kailangan i-expedite na natin ang delivery. Okay? Gusto ko, Doc, i-memorize yung category 2. Gusto ko category 2 lang ang i-memorize. Tuturuan ko kayo ng madalian, no? Pag may mga ganito, tables, okay, na compare, kahit isa lang i-memorize nyo. Okay, dito, dalawang i-memorize nyo. Yung category 1, normal yan, lahat normal. Okay, including early decelerations, ha. Pag may early deceleration ka, maybe present or absent, that is still normal. Alright. Pag category 2, ito yung hindi belong sa category 1 and category 3. Okay, ang category 3, this is abnormal. Absent baseline fetal heart rate variability, and any of the following: recurrent late, recurrent variable, bradycardia, and sinusoidal curve. Okay, so yung abnormal, yung i-memorize nyo. All category 2, no? Dito tayo magre-resuscitate. Okay, so ito ang meaning ng category 3. So this one, no, this is a category 1 tracing. This one is a category 2 tracing because of the presence of recurrent na variable decelerations, pero maganda ang variability. No? So category 2 yan. Category 3, this is sinusoidal pattern. Ganyan ang itsura ng sinusoidal. Ominous sign yan, deliver na yan. This is an ominous sign. This one, change in the baseline lang to. So ito ang pinapabasa sa inyo. So this is a category 1 tracing. How about this one? Sige, tingnan natin sa ating mga nasa Zoom. Can you read this? What kind of tracing is this? Check Toko. Di siya nagko-contract talaga, B. Ayan siya, oh. So what do you think is the problem here? Anong category kaya to ng tracing? Or NST ba to dahil di siya nagko-contract? Okay, sige. This one, ang baseline fetal heart tone niya is around 120. Walang variability. No, walang accelerations. Okay? And these are called spontaneous decelerations. No, late in configuration. Kasi hindi pa nga siya nagko-contract. No, may mga decelerations na siya. So these are spontaneous decelerations. This is a category 3 tracing. Okay? Alright, so okay na tayo doon. Questions, clarifications? Okay, now let's go to labor and delivery. Okay. Remember your stages of labor? This came from blueprints. Blueprints to. Kasi ang gulo ng gulo ni Williams dito sa part na to. Stage 1 of labor is onset of labor until full cervical dilatation. For nulipara, sabi sa blueprints, it's 10 to 12 hours. But it can last mga 6 to 20 hours. Average na 10 to 12 hours. May question pala dito, sorry. Paano malalaman if yung tanong is from Blueprint or Williams? Medyo magkaiba talaga sila. So, titingin ka ng mga context clues, babe. Later, sabi ko pa yung mga ibang context clues na nakita ko. No? So again, nulipara, it's 10 to 12 hours. Pag multipara, it's 6 to 8 hours in average. No? Pwedeng 2 to 12 hours mag-last yan. Again, this is stage 1. From contraction to full cervical dilatation. Onset of labor is contraction, regular contractions. Okay, next. Meron dyan latent phase and active phase. Okay, latent phase, onset of labor until 6 cms. Okay, nagkatalo-talo kasi sila dyan kung 4 ba, active labor na. So, pinagkaisahan na nila 6 cms na. Alright, so 6 cms ang pina-follow natin. That's your active labor already. Yung active phase, of course, follows your latent phase. Dito nga, sa Friedman, ano pa rin siya? 4 cms. Actually, 6 na yan ngayon. Okay? Stage 2, full cervical dilatation to delivery of the baby. Dito nagkakagulo yung mga tao. Pag nulipara, 3 hours without epidural. With epidural is 4 hours. Ang nakasulat sa blueprint, 3 hours plus 1 hour if there's epidural. So, naging 4. Okay? Pag multipara, 2 hours without epidural. With epidural, it's 3 hours. Okay? This came from blueprints, ha? Okay. Next. How do you monitor naman non-reassuring fetal status? So, di ba, magde-deliver ka ng baby. So, you will monitor the baby. Pag non-reassuring fetal status, may repetitive na late decelerations, bradycardia, or loss of variability, how do you manage? Ito yan. You discontinue oxytocin, O2 supplementation via face mask, and turn to the left side. Left lateral decubitus position. Pwede bang right? Pwede naman ding right. Okay? Pero sanay lang tayo left lateral mo yan. This is intrauterine resuscitation. When you say hypertonus, the contraction is lasting for more than 2 minutes. Ang tachysystole, 5 contraction in 10 minutes. So kailangan mo talagang i-discontinue yung oxytocin pag naka-oxytocin siya. Pag hindi naman, kung na-discontinue mo na yung oxytocin, you have to give terbutaline. Again, this is for non-reassuring fetal status on the 2nd stage of labor. All right. 3rd stage, stage 3. It's the delivery of the baby to the delivery of the placenta. No, it can last up to 30 minutes. Pag 30 minutes na, hindi pa rin lumalabas yung placenta, we can do manual extraction of the placenta. Okay? Ito yung kanina, 3 signs of placental separation. This came from blueprints. Tatlo yan. Cord lengthening, gush of blood, and uterine fundal rebound. Yung uterine fundal rebound, supposedly, pagka-deliver ng baby, no, yung uterus, yung fundus, is at the level midway between the umbilicus and the pubis. Okay? But then, no, pag nagkaroon na ng placental separation, isang sign doon, umaangat yung fundus, napupunta siya near the umbilicus. Yun yung uterine fundal rebound. Okay? So ito, sabi to sa blueprints. Sa Williams, 4 yan. Pero hindi na mention na ang tawag dun sa isa pang sign is Calkin sign. So kung nakakita kayo ng Calkin sign, hindi yan galing sa either Williams or blueprints. Galing yan sa CPG. Okay? Or kung ano mang internet. Sa internet sa galing ang Calkin sign. Okay? So, yun yung mga makikita nyo, yun yung mga difference between blueprints and Williams. So sa Williams, merong gush of blood into the vagina. Ito yon, a globular and firmer uterus. Kasi, ito yung tinatawag, ito yung sabi nila na Calkin sign, di ba? Calkin sign. Globular and firmer yung uterus because when you deliver the baby, nagiging discoid. Nanap ko pa talaga yung ibig sabihin ng discoid. Parang flat. Nagiging parang flat yung uterus pag dineliver mo na yung baby. Pag magsaseparate na yung placenta, nagiging globular and firmer yung uterus. Nagiging ovoid siya ulit. Para siyang nagkakalaman. So yun yung Calkin sign. Nagiging globular and firmer yung uterus. Lengthening of the umbilical cord, just like in blueprints, and elevation of the uterus into the abdomen. That is uterine fundal rebound. Okay, umaangat siya. Anterocaudal. Diba? Ay, anterocaudal. Tama ba? O basta paangat siya. Papunta siya ng umbilicus. Okay? Elevation of the uterus into the abdomen. We'll discuss also episiotomy. Okay, third stage na to. Episiotomy, na-deliver na yung baby. So mag-episiotomy ka. So you have 2 types, your median and your mediolateral. Okay, pag median, this is the most common. Okay, but usually resolves to 3rd and 4th degree. Ito yung disadvantage niya. So pag maiksi ang perineum, no? Pag less than 2 cms, you go for mediolateral. Less than 2 cms. Ang perineal body, you go for mediolateral. Because fewer ang 3rd and 4th degree extension. Okay? Fewer ang 3rd and 4th degree extensions. Pwede bang anong ginagawa natin sa clinic? Right? Right mediolateral, pwede left? Sige, tanong nga natin. Para mag-isip tayo ng konti sa Pwede kang left? Bakit pa puro right? Kaliwete ako, Doc. Gusto ko left. Pwede? Tingnan natin. Anong sagot ng mga BBs ni Doc DK here? Pwede. Very good. Oh, pwede. Pwede namang mag-left. Okay. Pwedeng right, pwedeng left. Now, hindi lumabas yung baby. CS ka na. So these are the indication for cesarean sections. Ika-clarify lang natin. The most common indication for cesarean section is previous cesarean section. Okay, previous cesarean section. But the most common indication for primary cesarean section is cephalopelvic disproportion. Diba? Malaki yung head, maliit yung pelvis, di lumusot. Maliit yung pelvis, sakto lang yung head, di pa rin lumusot. Power, passenger, and passages. Usually ito sa passenger and passages ang problema. Cephalopelvic disproportion. Cephalohead, pelvic, pelvis, disproportion. Di sila magkatugma. Di sila lulusot. Okay? So again, pag tinanong sa boards, most common indication for CS is repeat CS, previous cesarean section. Okay? Pag primary CS, meaning ngayon pa lang siya ooperahan, it's cephalopelvic disproportion. Okay? Now let's go to early pregnancy complications, no? Ito abortion and ectopic pregnancy. So the most common site of the ectopic pregnancy is tubal, fallopian tube. Pinaka-common ang ampullary, no? Pinaka-delikado because of the massive blood loss is interstitial or cornual. Pag sinabi mong cornu, part yon ng uterus. Pag sinabi mong interstitial, part na yon ng fallopian tube. So kung interstitial, no, ang management dyan is cornual resection pa din. Okay? Excuse me. Meron din tayong tinatawag, baka matanong sa inyo, tong heterotopic pregnancy. Heterotopic pregnancy is multiple gestation with at least one intrauterine. So meron kang intrauterine and at least one ectopic pregnancy. So heterotopic pregnancy. How do you manage? Itong heterotopic pregnancy, pareho ng management ng ectopic pregnancy. Pero hindi natin papakailaman yung intrauterine pregnancy. Okay? Wag lang nating matanggal ang corpus luteum. Kasi on ultrasound, may ring of fire pareho. No, ring of fire. Pag narinig niyo yung ring of fire, it's either corpus luteum lang yon or ectopic pregnancy. On ultrasound, pwedeng ma-detect siya as heterotopic pregnancy, pero sa totoo, it's the corpus luteum. So pag tinanggal natin yung corpus luteum, what will happen to the baby? Yung corpus luteum produces progesterone, no? Yung nagme-maintain ng pregnancy. So pag tinanggal mo yon, akala mo heterotopic, your baby will die. Okay? Okay. So anyway, balik tayo ng ectopic pregnancy. Meron kasi kaming ganong case dati paglabas ng histopath, corpus luteum. So anyway, so management of ectopic pregnancy, surgical pag unstable with rupture, XLAP, stable with probable rupture, XLAP pa din, no? Cornual resection of ectopic pregnancy pag cornual. So yung mga ginagamit natin dito, no, na surgical technique, salpingostomy. Pag salpingostomy, tatanggalin mo lang yung pregnancy. You leave it's either you do salpingostomy open, pasayaan mo na lang siya mag-heal by primary intention. Pag salpingectomy, tatanggalin mo yung whole fallopian tube. Pag cornual resection, this is for interstitial pregnancy. So ito yung mga surgical techniques na ginagawa. Pre-post test po, the answer is failure of labor to progress. Titingnan ko, Doc Yana, yung sa pre-post test. Ano yung practice test ba yun? Sige. Hindi kasi ako yung gumawa ng practice test. Wait lang ha. May CTG reading, walang CTG reading. Wala namang CTG reading sa PLE, no? Dinedescribe lang natin siya. Binibigyan ko lang kayo ng picture para mas maintindihan nyo siya. Mali mo, sa utak nyo, sa maisip nyo siya, di ba? Matanong. Ang tinanong na dyan is variability. Tinanong na ang variability at saka ang acceleration support. Yung mga previous board exam. Yun yung mga tinatanong. Okay. You can also manage ectopic pregnancy pag through medical management with the use of methotrexate. Your methotrexate is a folic acid antagonist, but meron sa dapat nito. This is from Blueprints. Asymptomatic, compliant, and hemodynamically stable. Minsan kasi pumupunta na mga pasyente sa ER, no? Hinihimatay na dahil wala ng blood. Okay? Nag-hemoperitoneum na sila. Nag-rupture na. So hindi pwedeng i-methotrexate yon. Low beta HCG, usually less than 5,000 milli-IU per ml. Small ang ectopic pregnancy, the size is less than 3.5 cm. And no fetal cardiac activity. Bakit? Can someone tell me, bakit kailangan patay yung baby? Pag buhay, hindi mo siya i-methotrexate. Okay. Sige, may alam ba ng sagot? Hindi increase failure rate actually. No fetal cardiac activity dapat because you would know that if you give methotrexate, okay, since it's a folic acid antagonist, the baby will die. Okay? The baby will die. All right. So actually, it's the principle of double effect. Okay? Hindi mo gustong patayin yung baby. Ang gusto mo lang, ma-save yung mother. So kung isi-save mo yung mother, pwede kang mag self-injectomy. Kung buhay ang baby, no? You do self-injectomy kasi pag self-injectomy, you just remove the diseased fallopian tube. Okay? But you will not kill the baby. Okay? So actually, principle of double effect lang yan. Alright? Next, we'll go to abortion. So these are the types of abortion. Meron pa itong kasama dati na imminent. No? Pero sa blueprints at saka sa Williams, wala na yung imminent abortion na talaga. You have threatened, missed, inevitable, incomplete, and complete. Pag inevitable and incomplete, open yan ang cervix. Okay? Pero pag inevitable, no, compatible pa yung uterine size, okay? Meron pang heart rate yan minsan or wala, depende. Okay? And you do curettage for inevitable abortion. For incomplete, you do completion curettage. Actually, pareho lang yan. Okay? Do curettage. Inevitable and incomplete. Wala na tayong imminent. Alright? This is for abortion. Meron kasing isang question about abortion. Pag naalala ko, sabihin ko sa inyo. No. Meron palang nagtanong, kung yung kung inevitable abortion daw ba, pwede ka pang mag-cerclage. Halimbawa, ang cause is cervical insufficiency. Kung pwede ka pang mag-cerclage. Pag inevitable abortion, wala nang role ang cerclage kasi remember, your bag of waters is already ruptured. Okay? Wala nang ang cerclage dito. Sa threatened abortion, pwede. Ang threatened abortion kasi, no, ang threatened abortion kasi, pwede yan, kung halimbawa nag-open yung cervix, painless na pag-open ng cervix, pwede ka pang mag-cerclage. Okay? Pwede ka pang mag-cerclage. So the probable causes of abortion, ito yung laging tinatanong. So for first trimester, the most common cause of abortion is abnormal chromosomes. Your autosomal trisomy, no, is the most common abnormality that causes abortion. Okay? Others, pwedeng infection, maternal anatomic defects, immunologic factors, environmental exposures, or endocrine factors. Pero hindi yung mga pasyente natin na naglaba lang, napagod, nakunan. No, pag first trimester, napagod kasi ako, Doc, kaya ako naglaba kasi ako, Doc, kaya ako nakunan. Ako, investigate nyo yan. Induced abortion yun. Okay? For second trimester abortion, ito yung 12 to 20 weeks, pwedeng infection, pwedeng maternal uterine and cervical anatomic defects like your cervical insufficiency, maternal systemic disease, exposure to phytotoxic agents, or trauma. So dito yan sa second trimester. Okay? Second trimester abortion. So again, abnormal chromosomes are not a frequent cause of late abortions, usually pag mga first trimester abortion. Now let's go to obstetrical hemorrhage. You have your antepartum hemorrhage and postpartum hemorrhage. Ang antepartum hindi pa nagle-labor, no, pero pwedeng mag-bleed. Like your upshaw, your placenta previa, your vasa previa, and your uterine rupture. Pag non-obstetric causes naman, pwedeng cervicovaginal laceration, lesions, or hemorrhoids. Pag postpartum, you have early versus late, no? Ang 40s tone, pag postpartum hemorrhage, this is the 40s. Tone, tissue, trauma, and thrombin. Okay? Tone, tissue, trauma, or thrombin. So pag antepartum hemorrhage, kailangan nyo, ito yung mga usually na tinatanong, no? Causes of, the leading cause of maternal death in the US and one of the leading causes of perinatal morbidity and mortality. So placenta previa is 20% of antepartum hemorrhage, of causes of maternal death, 30% ang placental abruption. Okay? Pag placenta previa, pag ito nakita nyo, placenta previa, partial previa, marginal previa, low-lying placenta low-lying placenta. Pag nakita niyo yung mga terms na yan, ito ay galing sa blueprints. Kasi ang galing sa Williams, dalawa na lang yan. Placenta previa and low-lying placenta. Hindi niya na kino-complete previa, partial previa, wala nang ganon. So pag nakita niyo tong mga terms na to na naka-flash, this is from blueprints. Pag sinabi lang na placenta previa at saka low-lying placenta, galing yon ng Williams. A complete previa completely covers the internal os. Pag partial previa, portion lang. Ang marginal, nasa margin lang siya ng os. Low-lying, less than 2 cms. Vasa previa naman, fetal vessels lie over the cervix. Yun yung nagpa-present. Okay? So lahat to, hindi mo pwedeng i-IE. Okay? Same with placenta previa ng Williams and low-lying placenta. Hindi rin tayo mag-IE. Low-lying placenta is less than 2 cms from the os. Okay? All the others, no? All the others, basta nasa birth canal, regardless kung medyo kalahati lang yung nako-cover niya, it's just placenta previa. Okay? Kasi pare-pareho rin lang naman ang management yun. Again, 20% ng placenta previa no accounts for antepartum hemorrhage. Occurs 1 to 5% of women with prior cesarean section and 5% associated with placenta accreta. Alam mo, kung ako i-memorize ko tong mga percentage na to, kasi ito talaga, yung mga percentage, hindi ko alam kung saan galing, pero at least natatanong to minsan, no? So, madali naman siyang i-memorize, no? 20%, plus 30% yung abruptio. Okay? The risk for concurrent placenta accreta depends, no, increases with the number of cesarean delivery. Kung nag-cesarean delivery ka, the first cesarean delivery, the risk is 3%, no, na placenta previa with accreta. Okay? Pag mas mataas, pag nakalimang cesarean delivery ka na, no, 67% ang risk mo of placenta previa with accreta. Ano to? Anong tawag dito? Biningo mo na lahat, ganyan, dalawa. So how do you manage placenta previa? Pag preterm, walang indication, close observation. Pag mature, you can schedule for cesarean section. Placenta previa is the one of the indications for early term like 36 to 37 or late preterm na cesarean delivery. Late preterm, early term delivery, cesarean section delivery is placenta previa. Labor had ensued with preterm fetus, you can do tocolysis para mag-stop yung contractions. Pag severe hemorrhage, emergency CS despite gestational age. Okay? So pag ito naman, let's go to placenta accreta. Ano ba ang placenta accreta? These are morbidly adherent placenta. Pag sinabi mong morbidly adherent placenta, galing yun ng Williams. Or placenta accrete syndromes, Williams yun. Kasi sa blueprints, ang sabi lang niya, placenta accreta. Ang nangyayari dito, wala kang metaboc layer, okay? So, ang nangyayari, decidualization mo is defective. Okay? So, absent yung metaboc layer mo. So, nagpe-penetrate siya. Di ba dapat ang placenta nasa endometrium lang, nasa decidual lang, dyan lang siya. Ay, sorry, nandito lang siya. Dito sa part na to. That's the normal. Pag accreta, attached to the myometrium. So, nag-attach siya sa myometrium na hindi naman dapat. Dito na siya sa myometrium. Pag increta, ini-invade niya na. Mas malala na siya. Ini-invade niya na ang myometrial layer. Okay? Ang percreta, penetrate na the myometrium. Papunta na siya ng serosa. So, anong management nito? Siyempre, hindi naman matatanggal ang placenta, duduguin yan. So, hini-hysterectomy ito mga. Pag dineliver, you have to do hysterectomy. Okay? Classifications ng placenta accreta, you have total, partial, and focal. Total, yes, failure. Sige, meron sinulat dito. Okay, primary, meron kasing question regarding the regarding the primary, the indication, most common indication for CS. Failure to progress in labor, that's also CPD, di ba? cephalopelvic disproportion, hindi siya nagkapag-labor kasi hindi nga lumulusot yung head. So that's the indication for primary cesarean section. But the most common indication for all types of all types of CS is repeat. Mas marami ang repeat na CS. Okay, so that's the most common. Kasi hindi lang, ganito yan guys. Pag primary CS, di ba, ang most common mo indication mo, CPD. Okay, or failure of progress of labor. Sige. Pero pag CS in general, lahat na ng mga na-CS mo dati at isi-CS mo ulit, kahit hindi naman ang indication niya is CPD. Let's say ang indication niya, dalawang twins. 'Di ba? Next pregnancy, isi-CS mo siya ulit. So, saan na siya? Doon na siya sa repeat CS. So, mas marami ang indication ng CS because of a repeat CS than a primary CS na dahil sa failure of progress of labor or your CPD or your dystocia. Okay? CPD, dystocia, failure of progress of labor to progress, lahat yan dystocia. Okay? So may question pa ba doon? Clear ba ako? Naintindihan ba? CS in general, iba yun sa primary CS. Ang primary CS is the first CS. Okay? Ano bang sabi sa blueprints? The most common indication for primary CS is failure of progress of labor. Primary CS. Okay? So, balik tayo dito. Pakiusap ko naman sa mga mother gusto na nanonood, pwedeng i-direct kay Doc DK. Thank you. Okay, para yung chat lang yung babasahin ko. Sorry na. Pagbigyan nyo na ako, be. Okay, pag partial, few or several lobules. Pag focal, isa lang na lobule. Okay? So this is for postpartum hemorrhage, di ba? Tone, trauma, tissue, thrombin. Pinaka-common dyan, uterine atony, tone. Soft, buggy uterus. Okay? Soft, buggy uterus. So ito yung mga pathways, na mga management natin, no? For uterine atony. You can give uterotonics in the form of oxytocin, your ergo derivative, your misoprostol, your carboprost. Okay, kung unresponsive, pwede kang mag-bimanual uterine compression, balloon tamponade, or uterine compression sutures, pelvic vessel ligation, angiographic embolization, and hysterectomy. So ang endpoint niyan, pwede kang mag-hysterectomy. Subtotal hysterectomy. Para mabilis lang. Pag subtotal, di mo sasama yung cervix. Yun yung ibig sabihin ng subtotal hysterectomy. You can do Bakri balloon or B-Lynch sutures. Okay? Pero pag nakikita nyo kasi siya sa clinics, no, unang ginagawa talaga, parang kung hindi nag-work ang carboprost, ang oxytocin, ang ginagawa, hysterectomy na agad. Hindi na sila nagbibilins, no, nagbabakri balloon. Okay? Diretso hysterectomy na. Okay? Pero syempre tayo, mag-exam tayo, kailangan nating malaman na may iba pang procedures for that. Now, let's go to preterm labor. It's labor that occurs before 37 weeks and may lead to preterm delivery. So magkaiba yung preterm labor sa preterm delivery. Pag preterm delivery, you have extremely preterm, very preterm, moderate to late preterm. Pag based on birth weight, extremely low birth weight pag less than 1,000, very low pag less than 1,500, low birth weight pag less than 2,500. Okay, so again, iba yung preterm labor sa preterm delivery. Okay, nanganak na siya, delivery. Hindi pa siya nag-labor. Okay, management. Pag 34 weeks or more, you can give corticosteroid, no? May be considered up to 36 and 6-7 weeks. Diba? Ito yung minention natin sa pedia. Okay, pwede hanggang 36 to 6-7 over 36 completed weeks. Okay, pag sinabi mong 36 completed weeks, pareho yan ng 36 weeks and 6 days. Okay, pero dun sa blueprints, hanggang 34 weeks lang talaga siya. So ito yung mga management natin. Now let's go to terminologies. Okay, preterm premature rupture of membranes. Pag preterm rupture of membranes, this is rupture of membranes before 37 weeks. Okay, pag premature rupture of membranes, this is rupture of membranes before onset of labor, 8%. 8% nagro-ROM. Okay, pag preterm premature rupture of membranes, both preterm and premature rupture of membranes, PPROM. Okay, pag prolonged rupture of membranes, this is 18 hours before delivery. So preterm rupture of membranes before 37 weeks. Pero actually, ito ay nasa blueprints lang. Pero ito ay spontaneous rupture of membranes rin. Spontaneous rupture of membranes, kahit na preterm ka, basta nag-rupture yung membranes mo because nagko-contract ka, that is still spontaneous rupture of membranes. Okay, naintindihan ba ako? Pag 30, halimbawa, 35 weeks, nagko-contract na siya, nag-preterm labor siya, nag-rupture yung membranes, it's not anymore PROM or PPROM. It is spontaneous rupture of membranes. So regardless of age of gestation, pag nag-rupture yung membranes because of the contractions, that's spontaneous rupture of membranes. Okay? So itong diabetes of pregnancy, i-show ko lang yung mga values, no, na nakita ko with the different sources. So ang ginagamit natin dito sa Pilipinas, ang nasa CPG natin is this one, ASGODIP. You know why? Kasi high risk tayo as Filipinos dahil mahilig tayo sa kanin. So ang ASGODIP values natin is the Asian Federation of Endocrine Society Study Group on Diabetes in Pregnancy. So gumawa talaga sila ng task force, no, para sa mga East Asians. Inisip ko nga kung East Asians ba tayo eh. Kasi risk factor ang pagiging East Asian. Siguro no, kasi Northeast saka Southeast Asia. So East pa din. 'Di ba? So kasama tayo sa mga high risk. So ito yung algorithm. Again, this is based from the CPG, hindi to Williams, hindi to Blueprint. Okay, so i-show lang natin to. This is parang nice to know. Okay, para din sa mga practice nyo in the future. So for low risk, mag-FBS ka. Ang cutoff natin, less than 92. Pag 92 to 125, no, GDM na yon. Pag FBS more than 126, that's overt DM already. Okay, pag low risk, normal naman, 24 to 28 weeks, 75 grams OGTT. And here are the values, no? Anyone abnormal, okay, GDM. Pag normal, after 24 to 28 weeks, repeat test 32 weeks or anytime if with signs and symptoms of maternal and fetal hyperglycemia. Okay, so ito yung for low risk. Hindi tayo kasama dito, huwag nating pangarapin. Ito yung mga risk factors. Again, sabi nga, South or East Asian. So pinagsama, Southeast Asian. Siguro East Asian tayo, no? Yan yung mga risk factors, no? Dahil kasama tayo dyan, ito ang ating algorithm for high-risk women. FBS on the first prenatal visit, no? Pag normal, 75 grams OGTT. Di naniniwala, 75 grams OGTT immediately. Okay? Doc, bakit hindi na lang tayo mag 75 grams OGTT immediately? Bakit kailangan pa nating mag-FBS? Remember, 75 grams OGTT, iinom ka kasi ng matamis na liquid. Okay? First prenatal visit, malamang yan, mga 10 weeks, 11 weeks, 12 weeks, susuka pa yan. Tapos painumin mo nun, magsusuka siya. So pwede namang FBS agad. No? Pwedeng FBS rin. Pero ako, in practice, dito na ako dumidiretso sa 75 grams OGTT. Okay? So 92 to 125 GDM. Pag more than 126, overt DM na yun. Okay? Now, ito ay galing sa Williams at Blueprints. Pareho lang sila. Blueprints pala to galing. Blueprints. At 24 and 28 weeks, 50 grams, glucose loading test, GLT, fasting and 1 hour after. If 1 hour glucose is more than 140, proceed to 75 or 100 grams glucose tolerance test. Ito ang mga cut-off values niyan. Sabi sa Blueprints, fasting, okay, less than 105 sa screening test, so 50 grams. Parang 1 hour 50 grams loading dose, 140. So yan yung cut-off niya. Medyo mataas yung cut-off nila kasi Americans to, hindi naman sila masyadong at risk. Okay? Sa Williams, sa haba-haba ng sinabi niya ng screening, pumayag naman din siya dito. Okay? So same lang. Same lang ang Williams, 50 grams glucose tolerance test. Glucose loading test, GLT, glucose loading test. So pareho lang to. Ang pagkakaiba nila is the values after the 100 grams OGTT. So pag nakita niyo yung 75 grams OGTT, malamang ang tanong sa inyo is the ASGODIP. Okay? Yung ASGODIP, yung sa CPG. Pag nakita niyo ang Carpenter-Custan, this one, kasi ito yung mga tinatanong sa amin dati nung nag-boards ako. Carpenter-Custan, galing yan ng Williams. Okay, so ito yung mga cut-off values niya, 95, 180, 155, and 140. Pag nakita nyo kasi na 3 hours, 3 hours yung tanong sa inyo. At the third hour, the value is 140 milligrams per DL. Ganyan. Ibig sabihin yan, 100 grams yan. Kasi ang 75 grams OGTT, 2 hours lang. Ang 50 grams loading dose, 1 hour lang. Again, 50 grams glucose loading test is 1 hour. Pag 75 grams OGTT, it's up until the second hour. Pag 100 grams OGTT, it is 3 hours. Okay? So ito yung mga values ng Carpenter-Custan. Kung ako itong memorize ko, Carpenter-Custan, tapos sa 3R, ito naman. Okay? So, yan yung mga differences ng mga 4 GDM. Okay? Now, let's go to hypertension in pregnancy. Pag gestational hypertension, more than 140, or diastolic, more than 90, more than or equal to 90. Or, so pwede kang 140 over 80, so gestational hypertension pa rin yun. O kaya 130 over 90, no? Gestational hypertension pa rin yun. After 20 weeks age of gestation with a previously normal BP. Preeclampsia without severe features naman is hypertension plus proteinuria, or in the absence of proteinuria, walang proteinuria. Ay, sorry. Ito naman, Trelicept. Basta meron ka nito, itong mga nandito, no, thrombocytopenia, renal insufficiency, no, liver involvement, cerebral or visual symptoms, and pulmonary edema, that is preeclampsia with severe features. Okay? Non-severe features pag wala to, kung hypertension lang talaga, tsaka proteinuria. Okay? There's also what we call HELP syndrome. There's hemolytic anemia, elevated liver enzymes, and low platelets. Okay? Ang eclampsia mo, meron kang seizure, non-attributable to other causes. When you say chronic hypertension, dito nagkakagulo, no? Sabi sa blueprints, it's more than 6 weeks postpartum, pero sa CPG kasi it's 12 weeks. Okay, 12 weeks. Kung ako, ang isasagot ko, yung nasa blueprint, 6 weeks. Sabi niya no? Chronic hypertension with superimposed preeclampsia, increasing elevated BPs, and new or worsening proteinuria. Okay? Halimbawa sa 16 weeks, let's say chronic hypertension, 16 weeks plus 1 ang protein. Okay? 28 weeks plus 1 pa rin ang protein. BP, ganun pa din. 140 over 90 ang BP. That is still chronic hypertension. Wala pa siyang preeclampsia. Pag nag-increase, okay, nag-increase ang BP, let's say 160 over 110. Okay, that's kasi severe feature na 160 over 110. So 160 over 110 ang BP, no, plus 1 pa rin ang protein. Superimposed preeclampsia na yon. 140 ang BP over 90. Chronic hypertensive, naging plus 2 at 28 weeks. That is now superimposed. May superimposed preeclampsia na siya. New or worsening proteinuria. Remember, marami kasing mga patients, no, kahit chronically hypertensive, may proteinuria yan. HELP syndrome, rapidly deteriorating liver function, hemolysis, and thrombocytopenia. Okay? You manage HELP syndrome, pag more than 34 weeks, you deliver. Actually, for cases of preeclampsia with severe features, you deliver at 34 weeks. Pag less than 34 weeks, delivered 24 to 48 hours after administration of betamethasone for lung maturity. No? You have to deliver the baby. Magnesium sulfate, of course, for prophylaxis. So preeclampsia, eclampsia naman occurs in 2 to 3% of women with severe features. So 2 to 3% nagpo-progress into eclampsia, nung may preeclampsia with severe features. So strategies in the management of preeclampsia, syempre, start with your ABCs. Pag nagsi-seizure, you give magnesium sulfate, BP control in the form of hydralazine or labetalol. No? You give magnesium sulfate na maintenance dose. You deliver the baby. Okay? Pag na-stabilize niya, tsaka na-control na yung convulsion. Okay? The most appropriate way to treat the fetus is to stabilize the mother by establishing adequate maternal oxygenation and cardiac output. So bibigay tayo ng magnesium sulfate. Magnesium sulfate, no? These are the clinical response to magnesium sulfate concentrations. Ang goal natin is to reach therapeutic levels, avoiding toxicity through careful clinical monitoring. Napaka-narrow kasi ng therapeutic window ng magnesium sulfate. Okay, itong mga values na to, 4.8 to 8, 8, 10, 15, 17, 20 to 25 is based on blueprints. Okay, sabi dito at 4.8 to 8.4, that's a therapeutic seizure prophylaxis. By 8, you have clinical depression, CNS depression. By 10, loss of tendon reflexes. Pag 15, respiratory depression or paralysis. Pag 17, coma. And cardiac arrest at 20 to 25. Napakahaba niyan, Doc. Correct. Sa blueprints yan. Sa Williams, ito lang. Okay. Sa Williams, 4 to 8, 10, saka 12. Okay, therapeutic, 4 to 8, patellar reflex at 10, 12, respiratory paralysis and respiratory arrest follows. Okay, so yun yung pagkakaiba ng blueprints and Williams. Okay? Okay, for chronic hypertension with superimposed preeclampsia, 1/3 or more of patients with chronic hypertension will develop superimposed preeclampsia. Okay? Hindi. Sorry. So urinalysis, pag trace lang ang protein, it's not pre-ec. +1. +1. Or a 24-hour urine albumin of 300. Okay. Okay. Epilepsy in pregnancy. No, may mga tanong rin kasi dito sa boards dati, no, mga past 2 exams, maraming tanong about seizure in pregnancy. So yung mga percentages niyan, there's increase in seizures, 17 to 33% of pregnancies. No, dun sa mga may seizure disorder na. Because decreased compliance in anti-epileptic drugs and decreased levels of circulating AEDs. No, because estrogen, mag-i-increase yung estrogen mo in pregnancy, increased function of the P450 enzyme, nag-i-increase yung hepatic metabolism. So yung circulating mo na AEDs na babawasan. Okay, however, progesterone seems to have an anti-epileptic effect. Okay, hormonal changes, added stress, and decreased sleep, lower seizure threshold. Ibig sabihin, kung dati magsi-seizure at this level, no, nagkonti yung AED mo, ngayon nag-i-increase yung seizure nagdi-decrease yung seizure threshold mo. No, magsi-seizure ka na lang bigla. Okay, the best predictor of seizure frequency in pregnancy appears to be the amount of seizures in the year prior to the pregnancy. Pag seizure-free ng 2 to 5 years, may attempt to complete withdrawal from AEDs prior conception. Again, this is prior conception. Some numbers here. Okay, epileptic women increased risk of fetal malformations even without AED. Okay, 46% epileptic women, even without AED, versus 2 to 3% of the general population. So, a targeted ultrasound at 19 to 20 weeks is necessary. Monotherapy, no, yung sinabi kanina, at the lowest possible dose is preferred. Increase in the rate of NTDs in patients on carbamazepine and valproic acid. Therefore, it is recommended for folate supplementation prior conception to prevent these NTDs. Di ba, ang usual dose natin is 400 micrograms or 0.4 milligrams. If you're using AEDs, you have to increase the folate to 4 milligrams per day. Okay, just like in those with prior neural tube defect babies. Okay? Okay, so that's it for OB. Okay, so may mga questions ba tayo for OB? Pagsamasamahin na lang natin later, no? So gynecology naman tayo. Sorry if I'm taking too much of your time. Mahaba naman yung ano, 'di ba? Kaya pa. Okay, gynecology, menstrual cycle. This is very important. Okay, remember sa menstrual cycle, dito umiikot lahat ng mga hormones na kailangan mong malaman. Okay, so HPO axis ang mga star dito. Your GnRH from the hypothalamus, hooray. Okay, from the anterior pituitary, your LH and your FSH. This will stimulate your ovaries to produce estrogen and progesterone. Okay, so ito yon, gonadotropin-releasing hormone, follicle-stimulating hormone, and luteinizing hormone. So sila yung mga star dyan sa hypothalamus at saka sa pituitary. Pagdating dito sa ovaries, ito ang star, estrogen, Estrogen has both negative and positive feedback effects on the FSH and LH secretion, correct? Yes. Okay. Causes maturation and maintenance of the fallopian tube, uterus, cervix, and vagina. Okay. Yung progesterone has negative feedback on the effects of FSH and LH secretion during the luteal phase. So, ang estrogen star yan during the follicular phase. Ang progesterone star yan during the luteal phase. So, discuss natin ng mabilisan ang menstrual cycle. Okay? So, again, ito na yung ating graph. Alright. Okay. Ang nasa x-axis natin is the day of the cycle. Di ba 28 days yan? Ang nasa gitna niyan, 14 days, i-divide lang natin into 2. Ang nandito is the hormone concentration, kung ano ang nangyayari, no, with the GnRH, LH, FSH. Alright. The menstrual cycle is divided into 2. The first 14 days is the follicular phase. The second 14 days is the luteal phase. Follicular phase dahil ang star dyan is the follicle. Luteal phase dahil ang star dyan is the corpus luteum. Alright. During the first 10 days, during day 0 pala, the GnRH will increase. Okay? The GnRH will increase. Dapat, dahil nag-increase ang GnRH, sasabihin niya sa pituitary, gawa kayo ng FSH and LH. Pero hindi yun ang nangyayari. Kasi ang nangyayari, okay, yung FSH, di ba umi-increase yung estrogen? There is, at first, yung FSH medyo tataas siya. Pag tumaas na siya, ginagawa niyang mature yung follicles mo. Ito, okay, your ovarian follicles. Your ovarian follicles will now produce estrogen. Okay, so you'll now produce estrogen. Okay. This estrogen will have a negative feedback to the pituitary. Sabi niya may estrogen naman. No? Okay na, wag na kayong dumami. So yung LH, chill lang siya dyan. Yung FSH, tataas siya, tapos bababa siya. Kasi may estrogen na. Diba? Your follicles, while they are maturing, okay, nagpo-produce siya ng more estrogen. Now, at around day 10, yung GnRH mo, tuloy-tuloy lang yan sa pagtaas, dead ma siya. Yung estrogen will reach its highest level. When it has reached its high level, it will now send a positive feedback to the pituitary. Sabihin niya sa pituitary, oh, marami ng estrogen. Anong gagawin mo? Dahil positive feedback, maraming estrogen, anong mangyayari? Magkakaroon ka rin ng maraming LH. At low levels of estrogen, it will have a negative feedback to the pituitary. Low levels, the pituitary, huwag ka na munang mag-make. So that is negative feedback. But at high levels of estrogen, at high estrogen concentrations, it will have a positive feedback to the pituitary at sasabihin niya, gumawa ka ng maraming LH. So that is your LH surge. So the LH surge is because of the increase in estrogen levels. Okay, so yung FSH mo, chill lang siya dyan, tapos meron din siyang surge as a side effect of the LH surge. Yung GnRH mo, pataas lang siya. Dead ma lang yung GnRH mo, gawa-gawa lang siya ng gawa-gawa. Okay, so yung estrogen, magpipeak siya. Now, after ovulation, what happens? After ovulation, yung natitira mong follicular cells will become, yung luteal cells mo, yung follicular cells mo kasi ang granulosa cells mo, sumama siya sa egg cell, no? So anyway, so yung luteal cells mo na natitira, magiging corpus luteum na yan. Okay, magiging corpus luteum. What does the corpus luteum produce? It produces progesterone and inhibin and a little estrogen as well, no? So yung estrogen mo meron pero pababa na siya. Yung progesterone mo, no, dumadami siya tapos bababa rin siya. Yung inhibin mo, totally wala siya dito, tapos yung luteal phase, no, umangat siya pero bumaba rin siya. Bakit sila bumababa, Doc? Nakikita niyo ba yung corpus luteum? Ang laki niya dito, 'di ba? Tapos paliit ng paliit. So yung luteolysis, no, yung pagliit ng corpus luteum, mas konting hormones din ang naproproduce niya. Okay? So mas bumababa sila ngayon. Okay? Your inhibin will inhibit your GnRH. O sa wakas may nag-inhibit na sa GnRH, o pababa na siya. And it will inhibit your luteinizing hormone as well. So mababa na siya. Yung FSH, no, dahil wala naman siyang follicle na isi-stimulate, bababa rin siya. Okay? The end effect, mababa silang lahat. So isang cycle na naman ulit. Ulit-ulit lang. Alright? So that is your ovarian cycle. Ang similarities nito with your endometrial cycle, okay? Pag follicular phase, ano to? Proliferative. Pag luteal phase, ano to? Secretory. Follicular phase, kumakapal. Ay, sorry. Proliferative. Kaya siya proliferative. Kumakapal ngayon yung lining ng endometrium. And this is primarily because of the estrogen. Ang estrogen, pinapakapal niya yung lining. Ang progesterone, sinastabilize niya, hindi niya pinapakapal. Okay? So, ganun yung nangyayari. Pag mataas yung estrogen, kakapal yung endometrium. Okay? It will thicken. Tapos, numinipis din yung pag progesterone, okay? Pag progesterone, di ba sinastabilize niya? Eh dito, sa end na to, nawala yung progesterone mo. So anong mangyayari sa follicular phase, ay sa endometrium? Nawala na yung progesterone magbe-bleed na. So that leads to menstruation. Wala na nagsastabilize So menstruation, again, is withdrawal bleeding from the progesterone effects. Okay? So, magagamit niyo yan sa mga OCPs, ganyan, di ba? Pag winidraw natin yung OCP, halimbawa 7-day pill-free interval, dun sa 7 days, magbe-bleed siya kasi nawala na yung actions ng progesterone. Okay? So, yun yung nangyayari sa withdrawal bleeding. Next, this is menopausal hormone therapy. No? May tanong kasi dito, siguro mga isa lang. Regarding menstrual hormone therapy. No? It includes estrogen and progesterone. Lagi silang magkasama, hindi lang estrogen. Okay? Pero yung estrogen reserved for women without an intact uterus. Kasi nga ang ginagawa ng estrogen, pinapakapal niya yung lining ng uterus. So ibig sabihin nun, pag unoppose yung estrogen mo, wala kang progesterone, okay? Mag-i-increase yung incidence mo of endometrial intraepithelial neoplasia, hyperplasia, and endometrial cancer. 'Di ba? Ano bang pathogenesis ng endometrial cancer? 'Di ba? Unopposed estrogen stimulation. Okay? The new treatments include SERMs, okay? And your tissue-specific estrogen complex. Itong TSEC, pag narinig nyo to, okay, this is estrogen plus a SERM. So it's a combined conjugated equine estrogen, just like your Duo-V, with bazedoxifene. Bazedoxifene is a SERM. Hindi mo na kailangan ng progestin pag ito yung gagamitin mo because it already has an antagonistic effect on the uterus. So hindi mo na kailangan magbigay ng progestin. Bazedoxifene is a third-generation selective estrogen receptor modulator. Okay? This table is a summary of the major effects and benefits and risks of estrogen progesterone therapy and estrogen therapy. Okay? So sinasabi lang dito na with colorectal cancer, pag decrease ang estrogen and progesterone, pag estrogen and progesterone, magde-decrease ang risk. Pag estrogen only, mag-i-increase ang. Okay? Pero pag dementia, pareho naman sila. Okay? The recommendations for women with moderate to severe VMS, vasomotor symptoms, or genitourinary tract symptoms, MHT is the recommended treatment. Okay, MHT is recommended for the prevention of osteoporosis, but not the treatment of osteoporosis. For women, kung ang symptoms niya, genitourinary symptoms lang, low-dose vaginal estrogen can be recommended. Doses should be at the lowest effective dose. Extended therapy, pag na-understand ng patient yung risk and benefits and desired treatment continuation. More chorva. Okay? Yan. Pag gusto niya ng MHT. These are the contraindication. Pag may estrogen-dependent neoplasm of the breast, ovary, and endometrium, do not give MHT. Okay? Treatment must be considered carefully, however, particularly in older women. MHT should not be used for the prevention of other chronic diseases. Kasi diba estrogen has a protective effect sa cardiovascular disease, coronary artery disease. Hindi siya dapat gamitin for the prevention of. Okay. Now let's go to AUB. Baka lang matanong sa inyo to, no? Ito na yung mga bagong classification, FIGO 2018, pero ang blueprints ito pa rin, 21 to 35 days, 28 plus minus 7 days. Okay? Ang duration niya up to 4 days, flow volume is 35, no? 35 cc ang average, with a flow volume na 55 to 60 ml. Pero pag nakita nyo tong patient determined na light, normal, heavy, malamang FIGO 2018 yung kinuhaan nila. This one also, nasa handout nyo to, no? Yung mga may menorrhagia. Ito kasi yung naisip namin kung bakit talaga siya galing ng blueprints. Kasi may mga tanong pa na menorrhagia, metromenorrhagia, hypomenorrhea, no? So this one are the patterns of abnormal uterine bleeding. Nandito rin sa table na to, ito ka-clarify ko lang, nandito rin sa table na to ang amenorrhea primary amenorrhea. Okay? Again, ang primary amenorrhea, pag amenorrhea lang ang tanong, it's 15 years old. Ito, no menses by 14 years old pag nasa table na to on AUB. Parehong blueprints yun galing, ha? Okay, so medyo mag-iisip tayo ano kaya yung mga tinatanong. Pero ang usual na tanong about amenorrhea, no, tinatandaan nila parang mga, they make it older, 16.5 years old, ganyan. No? Basta more than 15, okay, that's primary amenorrhea. That's a primary amenorrhea. The classification is AUB, no, structural and non-structural. Ang structural mo is the palm, polyp, adenomyosis, leiomyoma, malignancy and hyperplasia. Again, M, malignancy and hyperplasia. Pag tinanong kayo tungkol sa complex hyperplasia, anong klaseng AUB yun? It's AUBM, no? Hyperplasia. Okay? Malignancy and hyperplasia. Minsan kasi hindi natin naaalala ang hyperplasia. Minsan nga ang malignancy natin na M nagiging myoma. Ang leiomyoma, ang fibroids ay AUBL. Okay? So this one are the mechanisms of bleeding for the various structural and non-structural causes of AUB. Okay? It's important to note na yung iatrogenic ay dahil sa medications. Kahit anong medications, OCP, okay, OCP, mga antifibrinolytic agents, no? Tapos nabibleed ka pa rin, it is due to medications. Basta gamot. Regardless kung para saan mo siya ginagamot. Let's say for von Willebrand, nagbibigay ka ng mga anticoagulative drugs, no? It is, basta due to medications, nag-AUB ka, it is iatrogenic. Okay? Pregnancy test, again, no? What you should do is have a pregnancy test first, especially for reproductive aged women. Your CBC, your thyroid function, your coagulation profile, pap smear and screening for STIs. This is for not otherwise classified kasi pwedeng ang mga chlamydia, no, or mga trauma, mga foreign bodies can cause bleeding also, infections. Okay, so AUB, ento. Serum ferritin, of course, if to show if you have anemia already because of the AUB. Okay, for imaging, no, ultrasound is the first line diagnostic tools. This is usually for the palm, for the structural causes of AUB, SIS also, no, or hysteroscopy. Okay, treatment of acute hemorrhage. Okay, intravenous estrogen is given, no? 25 milligrams conjugated equine estrogen every 4 hours up to 24 hours. Ito ay galing sa Compregyne. Kasi wala naman tayo nito sa Pilipinas. Wala tayong IV estrogen. Wala tayong high dose. Okay.
Dose, mana akong AirPods. Kaya kung high dose, can you still hear me?
Yes, Doc.
Okay. Pag high dose estrogen, no, pwedeng oral lang yan. oral estrogen. Wala rin tayo niyan. Meron tayong monophasic OCP. Actually, wala nga eh. Meron pa tayo nung may progesterone. Okay lang yun. 35, ito yung binibigay talaga natin. No? Dito sa atin. Pag acute hemorrhage. Okay? Wala kasi tayo nito. Doc, bakit ay ang cause nga ng pagbibleed niya? Let's say maraming estrogen. Your estrogen kasi can cause clotting at the capillary levels. Okay? Tapos, nakakapag-shed rin siya ng uterus ng mas maayos. Pag high dose of estrogen. No? Pag high doses of estrogen. Pag high dose of estrogen, nagbe-bleed ka, Doc, pero estrogen pa rin ang binibigay mo dahil nga sa estrogen. High doses of estrogen promote rapid endometrial growth. Okay? So mas mag-grow yung endometrium mo and clotting at the level of the capillary. Kaya high doses of estrogen ang binibigay. Okay? Now let's go to infertility. Dito ang mga tanong, mga percentage, mga numbers. So again, average conception rates for all couples, no? 20, 60, 75, 80, 90. Ibig sabihin, no, pataas, mas matagal silang chumuchorva, mas malaki ang chances of winning. All right? So within 18 months, 90% of couples with regular sexual contact will get pregnant. Sorry, may mali ako dito, may typo. Next 9 months, 75. This is fecundability. Fecundability is the ability to achieve pregnancy in a month, in one cycle. So that's fecundability. For the first 3 months, it's 20 to 25, pero for the next 9 months, it's around 75%. Fecundity is the ability of achieving a live birth in a single cycle. So yung fecundity mo will always be lower than fecundability because of the factors in miscarriages. Okay? So ganon. So this one came from blueprints also, yung explain ni Doc Broly kanina, no? So ang point ko lang dito, ang female factor at male factor halos pareho lang. So ba't laging nasisisi ang mga babae? So this is a study in 2014. Okay? So ito yung pinaka-source talaga sa exam. Ito yung pinaka na babanggit, no? Itong mga to. Feeling ko yung yung tubal factor dun sa isang table kanina na present, yung nasa handout nyo, na mas mataas kesa sa ovulatory, sinama niya kasi yung endometriosis. No? Sinama niya kasi yung endometriosis sa tubal factors, if you check. No? It's either that or nagka-typo. Basta ang most common cause of female factor infertility is an ovulatory and ovarian factors. Okay, so pag natanong kayo sa exam, most common ang ovulatory factors pa din. Ito rin natatanong, no? WHO classification of an ovulation, 1, 2, 3, 4. No? I-memorize nyo itong number 2, normogonadotropic, normoestrogenic. Okay, yung 4, madali lang yan, hyperprolactinemia. Alright? So, itong table na to, isa puso nyo to. Kasi mga 3 times na tong natanong. WHO classification of an ovulation. Meron lang to sa blueprints. Wala to sa William. Wala to sa Compreguide. Okay, this is from blueprints. For male factor infertility, ang common na natatanong, varicocele, 30 to 40%. No? Most common, reversible cause of male factor infertility. Okay, varicocele. Maraming mga causes, no? Pero ang reversible dyan, no, ang most common na reversible cause is varicocele. So laligate lang naman yung mga vessels. Now let's go to the infections of the lower genital tract. Pwede mo siyang i-classify as to drips and discharge. Pag drips, you have your gonorrhea, chlamydia, mucopurulin cervicitis, na parang galing din naman sa gonorrhea and chlamydia, candidiasis and trichomoniasis. Pag source, pwede siyang genital herpes, chancroid. Pag painless dyan is syphilis, lymphogranuloma venereum, and granuloma inguinale. Sige, isa-isayin natin. Genital herpes, chronic, lifelong viral infection caused by 2 types of HSV, HSV1 and HSV2. Ang presentation niya, may flu-like symptoms with vulvar burning and pruritus with multiple vesicles and painful genital ulcers. So it travels to the dorsal root ganglion. Titira lang siya doon. So habang buhay siya, kaya siya lifelong. Recurrence is more frequent than HSV2 infection. So nagkakaroon ng recurrence. Pero hindi na ganun kalala. Hindi na ganun kagrabe than your first, the initial episode. You diagnose this by NAAT. Okay? DAAT. Pwede ring chunk smear. You treat this with acyclovir from cyclovir or valacyclovir. Chancroid naman is painful and tender ulcer. Okay? Caused by Haemophilus ducreyi. Nagka-cry yung fish. No? School of fish. Ayan. Umiiyak yung mga fish. Haemophilus ducreyi, chancroid, kasi painful, kaya sila nag-iiyak. You treat this with azithromycin, ceftriaxone, cipro, or erythromycin. Syphilis, ang primary niyan is a painless chancre like this one, non-suppurative lymphadenopathy. So ang differences lang, ang gusto ko lang i-point out dito, there are differences in the management in the CDC 2015 and CDC 2021. Pero kung ako tanungin sa boards, dito pa rin ako sa CDC 2015. Okay? Kasi ito yung nasa blueprints. Ang difference niya, alright, is on the primary, secondary, early, latent. No, may alternative na siya na doxy, tetracycline for 2 weeks. So ito, may mga alternative na sila. May mga alternative dosing na sila. Okay, for the CDC 2015. Now let's go to vaginitis. Pag bacterial vaginosis, okay, thin whitish homogeneous fishy discharge. So ganyan yung itsura ng discharge niya. Pag yellow, frothy, with or without vaginal cervical erythema, strawberry cervix, think trichomoniasis. Candidiasis, pruritic, may white, thick, curdy, cottage cheese-like with intense pruritus, that's candidiasis. Pag bacterial vaginosis, trichomoniasis, you give metronidazole. Pag candidiasis, antifungal drugs. Okay, so ganyan ang tsura ng trophozoite. Next, condyloma acuminata. It's genital warts, caused by HPV. Pero yung mga low risk na HPV like 6 and 11. These are raised papillomatous or spiked surface pedunculated lesions or cauliflower-like growth. Ganyan, kaya itsura niya. Pag mas worse, ganito. May treatment dyan na patient-administered, your Podophilox, your Imiquimod, which are contraindicated to pregnant patient. Merong provider-administered, you can do excision, cryotherapy, podophyllin resin, or TCA. TCA is a chemical kind of pottery. For the upper genital tract, you have your PID and endometritis. Minimum criteria, very important. Please remember, lower abdominal tenderness or adnexal tenderness or cervical motion tenderness. These are just the additional criteria for diagnosing PID. But the definitive criteria is a histopathologic evidence of endometritis on endometrial biopsy. Okay? Pwede rin mag-TVS or MRI showing thickened fluid-filled tubes. Ano yon? Hydrosalpinx. Nasira na yung tube mo. Sa ultrasound, hindi yan makikita ang fallopian tube pag normal siya. Pag merong thickened fluid-filled tubes sa ultrasound, most probably you have hydrosalpinx, which is what happened pag may PID. Okay? Or if you have laparoscopic abnormalities consistent with PID. Ito yung Fitzhugh-Curtis syndrome. Bakit nga ba magiging cause yan ng ectopic pregnancy, ang PID? Kasi nasisira yung tube mo eh. Hindi niya na transport yung fertilized egg to the endometrium. Kasi sira yung tube mo. Hindi niya ma-transport, thereby can cause ectopic pregnancy. Doon na lang siya mag-implant sa fallopian tube. Pag may Fitzhugh-Curtis syndrome ka, most probably meron kang untreated PID kasi umakyat na siya eh. Nagka-peritonitis ka na, nagkaroon ka na ng ganito sa liver. Okay? Now let's go to CIN. So diniscuss natin kanina yung papilloma, yung human papilloma, ay yung warts. Again, low risk yon. It can be seen in CIN1 or condyloma acuminata. So ibig sabihin, hindi lahat ng may genital warts ay magkakaroon ng cervical cancer. Okay? Intermediate, know the serotypes. Pag high grade, know the serotypes also. Okay, yung cervarix, 'di ba? Yung cervarix, narinig niyo na 'yon, yung vaccine. Okay? Usually effective siya type 16 and 18, sa mga high risk. Yung Gardasil naman, Okay, type 6 and 11, and high-risk HPV type 16 and 18. So yung Gardasil, meron siyang protection against condyloma acuminata. Yung Cervarix dito lang sa high risk. Pero meron ng Gardasil 9. No? Gardasil 9 naman, it's the prevention of cervical, vulvar, vaginal, and anal cancers, and is effective against serotype 16, 18, 31, 33, 45, 52, and 58. Okay? So, ang may protection against warts is your Gardasil and Gardasil 9. So, let's go to abnormal cytology. So, yung mga abnormal pap smear. Abnormal pap smear can be, ito yung mga result pag pinap smear mo. ASCOS, ASCH, LSIL, HSIL, SCC, and AGC. No? Ito yung, again, ito yung mga pwedeng result mo when doing pap smear. Yung mga CIN, no, CIS, pwede yan when you do colposcopy with biopsy. Doon mo siya malalaman. Okay? Yung mga cancer mismo, no, makikita mo na yon. Hindi na siya microscopic. Okay? Kung makikita mo na yon, i-biopsy mo na. Okay? So, for cytology, ito yung mga screening test natin. Ito yung pinakabago, ACS 2020. Age less than 25 years old, no screening. Okay? Tayo, ang ginagamit natin ito. Cytology alone every 3 years starting age 21. Okay? Pag 25 to 65 years old, meron kang preferred, meron ka ng HPV test every 5 years. Acceptable co-testing. Co-testing is cytology plus HPV. Every 5 years, or cytology alone every 3 years. Okay? Ang ginagamit natin, cytology alone every 3 years until age 29. Ang preferred mo ay HPV and cytology co-testing every 5 years. Acceptable ang cytology alone every 3 years. Okay? Yung mga differences nila. This one, ito yung lumang guidelines. No? 21 to 24, tsaka more than 24 years old. Okay? Important to note, pag ASCH, regardless of the age, no, you do colposcopy. Pag HSIL, pag 21 to 24, you do colposcopy. Pag more than 24, meron ka ng ECC, endocervical curettage, or you can go ahead with LEEP. Okay? Pag glandular cells, ang problema, you have to do endocervical curettage and endometrial curettage kasi baka galing ng endometrium yung nakuha mong sample. So, kailangan mo siyang i-curettage. Pero hindi naman na yan ginagawa ngayon. Pero for the sake of your exam. Okay. Now, nakapag-colposcopy ka na, nakapag-biopsy ka na, ito ang mga result. Okay? Pag CIN1, tandaan nyo, basal third lang of the epithelium, that is maldysplasia. Pag CIN2, lower 2/3 of the epithelium. Pag medyo buong cervix na yung affected, that is CIN3. Okay, that is severe dysplasia, more than 2/3, including full thickness lesions. Okay, so ganyan yung nangyayari. How do you manage these CINs? No? Pwede kang ablative, okay, or excisional. Ablative, tatanggalin mo talaga siya. Like your cryotherapy or CO2 ablation. Pag kailangan mo pa ng specimen, okay, you do excisional in the form of LEEP, your loop electrosurgical excision procedure, or your cold knife conization. Okay? Yung LEEP, kukuha ka pa ng sample sa kanya. So, pwede mo pa yung ipa-send sa laboratory for histopath. Okay? Treatment of cervical dysplasia. Okay, pag CIN1, CIN2, CIN3. No, surgical excision, LEEP, or LETS. Pwede yan. Ano ba yung LETS? Large loop excision of the transformation zone, LETS. Okay? So, ang point dyan, mas tumataas yung level, yung grade, okay? Mas kailangan mo ng specimen. So, magli-LEEP ka o kaya LETS and surgical excision. Okay? Pag CIN, pwede kang repeat pap test or co-test. Okay? If any of the testing is abnormal, pwede kang repeat colpo with biopsy. Okay? Baka mali lang yung basa. Or baka nag-resolve na. No? There are a lot of cases na CIN1 ay nagre-resolve. So ito rin galing ng blueprints. Okay? So pag confined to the ectocervix, you can do a leap. Pag endocervix na yung involved, two-stage leap or CKC, no? Para ma-check mo kung meron din sa loob. Pag large lesion, pwede kang laser conization. Pag upper vagina involved, no? Laser conization. Okay? Based on the characteristic of lesion or patient. Okay? So, tingnan natin. Ovarian cyst naman. Ito, meron pala akong clarifications dito. Huwag niyo akong i-kill. Okay, ovarian cyst. Meron kayo sa handout na yung ovarian, may nakasulat dito na functional cysts. Okay? Ang functional cyst lang dito ay your follicular cyst, corpus luteum cyst. Sabi sa blueprints. Sa compregyne, kasama ang theca lutein cyst. Okay? Kaya nasama ang endometrioma dyan kasi diniscuss to sa blueprints na magkakasama silang 4. Okay? Pero pag sinabi mo kasing functional cyst, the cyst that persists because of the menstrual cycle. Nagkakaroon siya ng sa ovarian cycle. Like your follicular cyst, hindi siya nag-ovulate. So natitira yung follicle doon with the egg cell. Okay, lumalaki siya, that becomes now the follicular cyst. Yung corpus luteum, 'di ba? Your corpus luteum should regress, no? Meron kang luteolysis, hindi siya nag-luteolysis, naging corpus luteum cyst siya. Your theca lutein cyst naman is because of the abundant HCG, let's say in molar pregnancy, kaya ka nagkaka-theca lutein cyst. Yung endometrioma, meron kang endometriosis sa ovary. So therefore, ang endometrioma mo is not a functional cyst. Huwag niyo na akong i-judge. Ang functional cyst lang ito. Alright? Pero adnexal mass din siya, cyst din siya. No? Cyst din siya. So how do you evaluate? Again, you do a pregnancy test. Kasi usually, pag follicular cyst at saka corpus luteum cyst, ang nangyayari, hindi ka nagme-mens. Kasi nga, no, nahahalter yung ovarian cycle because nagpa-persist tong mga cyst na to. So, complete blood count, if there is hemoperitoneum, especially if ruptured yung corpus luteum, no, corpus luteum hemorrhagicum, or there is hemoperitoneum already. Screening for gonorrhea and chlamydia for UTI as indicated, no? Kasi pwedeng cystic mass, adnexal mass, pwedeng tubo-ovarian abscess. Okay? Transvaginal ultrasound, CT, and CA125, no? Pag and high risk for ovarian cancer. Kasi baka mamaya hindi pa naman pala siya hindi naman pala siya function, simple cyst lang. Okay? So CA125. So this is what we discussed kanina. Again, apologies sa reproductive na more than 7. Ayan talaga yung nakasulat eh. If there are changes. So further imaging, no, pag more than 7, if may changes dun sa imaging, nag-increase ng size, no, you have to do surgical evaluation. Sa postmenopausal, no, pag simple, no follow-up necessary. Pag more than 7, ganun din. Pag hemorrhagic, no, pag early menopause, you can repeat the ultrasound, but late menopause, you have to do surgical evaluation. Okay? So, thank you. So, we're done with our summary lecture in OB. So, sana marami kayo natutunan, maraming na-clarify. Maraming na-clarify sa mga katanungan nyo. Kung may tanong pa kayo, please, tanong nyo lang, try nating sagutin ng maayos na maiintindihan nating lahat. Alright. May questions ba kayo? Questions from the floor? Questions from the Mother Goose?
Yes, Doc. Good evening. May questions po, Doc.
Go.
Doc, ang tanong po nila kung same po ang management for CIN and cervical CA in pregnant patient.
I will check yung yung cervix
Kung same daw po yung management.
Anong stage ng cervical cancer yan sa pregnant? Depende kasi sa stage, no, ng cancer sa pregnant patients. Usually, pag mga later stage na, we have to remove the pregnancy. No? CS pa nga yan eh. Kasi hindi naman yan lalabas dahil nga adherent yung masses. Pero the main treatment for cervical cancer talaga is concurrent chemorad. Kasi nasabi niya yung CIN and pregnancy.
Yes, Doc.
CIN in pregnancy. I will check kung ano yung management ng CIN for pregnancy, ha? Sige. Hindi ako sure. Hindi ako magbida-bida.
Thank you, Doc. Ito pa, Doc, may isa pa. Kung consider daw pong preeclampsia with severe features, if yung BP niya is greater than or equal to 160/110 na may
Yes.
proteinuria in the absence of Trelicept daw, Doc.
Yes. Elevated BP na 160/110 is considered a severe feature of preeclampsia. So ang preeclampsia lang na without severe features ay hanggang 150/100. Ganyan. With proteinuria. Okay.
Okay, Doc. Last one, Doc. I think about contraception. Kung safe to use dual method in contraception such as progestin implant plus copper IUD.
Ayan, yun yung tanong kanina, no? Pag progestin implant at saka copper IUD, pareho yung long-acting reversible contraception. Actually, pwede ka halimbawa IUD at saka OCP or IUD at saka emergency contraception. Wala namang problema, no? Ang problema mo doon is the safety. Hindi naman mag-i-increase ang effectiveness ng parehong mga bagay-bagay. Like your IUD, pag LARC, let's say, hindi mag-i-increase ang effectiveness ng progestin implant at saka ng IUD. Pero yung side effects niya, parehong meron. Kasi remember, all your contraceptions, meron talaga yung mga side effects. Like yung like progestin only, no? Yung bleeding mo, erratic talaga yan. Okay? Tapos meron ka pang IUD. Kung may copper IUD ka, pwede ka rin magkaroon ng mga infections. So, maraming side effects. So, kung may patients kayo, or kung pili sila ng isa lang. No? Pwede namang isa lang. Wala namang problema. Unless, gusto mong mag-barrier method like condom. Kasi ang condom, aside sa anong tawag dito, contraceptive effect, no? Ang condom rin can prevent STI. So yung condom, pwede mong i-partner sa kahit saan doon. Okay? So any more questions, clarifications? Napagod ba kayo? Sorry. Ang ang haba pala ng summary lecture.
Kasi may OB and Doc. So I think they understand naman that kailangan talaga discuss. So yun, Doc. Thank you very much for that very high yield summary lecture, Doc. So thank you very much.
Thank you. Thank you, everyone.
Sige, mga B, ayan. Ano na tayo? Thank you, Doc Nina, again. So we'll have our Quizmaster para mabilis na tayo, okay? So hinga-hinga ng kaunti. Alright, Dr. Vidal is here already. I already introduced him earlier. So ang gagawin natin mga B, so prepare your answer sheets already. I will flash the questions for 30 seconds. Pag medyo mahaba, extend ko ng konti to 45. And then you answer them already on your own para later during the Quizmasters already, madali na tayo. Okay? So wait lang. I'll share my screen. Ayan, kita ba mga B? Okay, sige. Let's begin answering. Question number 1, 30 seconds. Question number 2. Question number 3. Question number 4. Tabaan ko ng konti. All right, question number 5. Question number 6. All right, question number 7. Okay, question number 8. Question number 9. All right, last question. Alright. Okay na ba mga bees? For the 10 questions? Okay. Sige. Dr. Vidal? Andito na ba si Dr. Vidal? Para mag-ano tayo? Start na tayo.
Hello.
Hi, good evening, Doc. Opo, na-introduce ko na kanina si Dr. Vidal. So, the virtual floor is yours, Doc.
Hi, thank you. Share ko lang po yung screen ko.
So mga bees, ilo-launch ko yung poll for 10 seconds and you can answer again. No, you can input your answer as we go along po doon sa ating 10 questions. I will launch a poll for 10 seconds para ma-input nyo yung mga sagot, para makita natin kung ano yung percentages of your answers. All right, so thank you.
Dige, pwede po bang pa-enable ng screen sharing po?
Ayan, Doc. Okay na. Okay na, Doc. Nakapag-share na kayo, Doc? Ayan. So if you guys have questions, all right, naka-mute po ata si Doc. Doc, naka-mute po kayo. Sorry. Sige. Ayan, we can see your ano, Doc. Ayan. Thank you.
Hello. So, ano yung screen naka-share, Doc? Sorry.
Ito, Doc. Yung Quizmaster, question number, wait lang. Yan, question number 1, Doc.
Oh, okay. Thank you. Thank you, everyone. So we'll go through the questions, all of them. So 5 questions for OB and 5 questions for Gyne. Pero for the most part, for the last boards, I think it was more OB than Gyne. So just expect that you will have more questions in OB than Gyne, and then next boards maybe. So let's go. So all of the following routine tests in prenatal care are usually done in 3rd trimester, except so most of you got it correct. Congratulations. 96% got of you correct now. So it's going to be maternal serum alpha fetoprotein. So remember MSAFP, it's a screening test for your aneuploidy, which is usually done in the 2nd trimester, no? So MSAFP is part of what we call the triple screen, di ba? As mentioned earlier. And kapag ano yung isang test na dinadagdag para maging quadruple screen siya? Can anyone mention it to chat box? Yes, it's inhibin A. So inad lang si inhibin, right? So that's essentially your screening test for aneuploidy. And for the 3rd trimester, we usually do RPR, VRL. No, it's a test for syphilis. No, so for syphilis, you need to do especially for high-risk populations, we do screening tests again in the 3rd trimester. And the next would be GLT, your glucose loading test. It's it's essentially a test for gestational diabetes mellitus. And lastly, it's your group B streptococcal culture. No? So if you have a patient who's GBS positive, then you offer penicillin in the 3rd trimester. So please remember your diagnostics in pregnancy. Medyo maraming lumalabas regarding this. Siguro mga 2 to 3 items in the boards. So next question, which of the following is true regarding cardiovascular changes in pregnancy? Okay, so It's 24% of you got the correct answer. It's actually letter B. So the lowest point of blood pressure occurs at 24 weeks age of gestation. So for letter A, your cardiac output actually increases by just 30 to 50%. For letter C, systemic vascular resistance drops secondary to progesterone, hindi estrogen. No? So remember, any maternal adaptation in pregnancy would usually be due to your progesterone instead of estrogen. And blood pressure returns to pre-pregnancy levels starting at 24 weeks age of gestation. So unti-unti siyang bumabagsak until term. So for adaptations in pregnancy, I think there would be probably 2 or 3 items. The most commonly asked questions would be about cardiovascular changes and also pulmonary respiratory system changes. So if meron kayong kakabisahin na maternal adaptation, I think CV changes would be one, and the respiratory system also. Palagi sila lumalabas. Okay. So next, which of the following would improve methotrexate success in patients medically managed for ectopic pregnancy? Okay, so most of you got it correct. 45% of you got it right. So the correct answer here is 3.5 centimeter size. So there are the other factors would actually be here, you know. Pero yung letter B, it's just gonna be no fetal heart tones in ultrasound. It was mentioned earlier too. Letter C is beta HCG should actually decrease by 15% post-treatment. Kasi kapag nagkaroon ka ng more than 15% increase despite of your methotrexate treatment, then you need to do another additional treatment. Right? And lastly, it should be beta HCG levels of less than 5,000 upon initial visit. So meron tayong expected decrease in beta HCG levels kapag nag-treat tayo with methotrexate. Pero high ang success kapag less than 5,000 upon initial visit. So sa OB, no, I think that for most diseases in pregnancy, it's gonna be like one item per disease. So parang one item for ectopic pregnancy, one item for placenta previa, for acrita, and all those other diseases. I think that the most commonly asked question would be about seizures. Like for the previous boards, it was probably 2 to 3 items of asking pharmacological actions of your drugs used in seizure disorder. So yun lang, no, medyo lapad yung spread ng OB/GYN and ng obstetrics part. Medyo lapad siya. So kailangan at least kahit paano may alam kayo kahit paano per disease, no? So for ectopic pregnancy, of course, your most common site of implantation would be your ampulla of your fallopian tube. The cardinal signs are 3, no? Triad, no? It's going to be vaginal bleeding, abdominal pain, and amenorrhea, no? So I think it was one of the clarifications earlier between vaginal bleeding and amenorrhea. Remember, amenorrhea, it's more describing the absence of menses for the past few weeks. Vaginal bleeding is just the initial onset of bleeding, no, despite the absence of menses. So yung tatlong yan would warrant a differential diagnosis of ectopic pregnancy. And you have 2 different treatments, like regimens for treatment. One's going to be single dose and multi-dose. Obviously, multi-dose would be more effective. And remember also that it's going to be there's going to be complications of methotrexate too. So usually, what the complications of methotrexate would always involve systems that are rapidly proliferating, no? So kaya contraindicated ang pregnancy kapag meron kang positive heart tones kasi yung baby mo ay isang malaking rapidly proliferating mass. And so also pag kung tignan din niyo, meron ding hematologic dysfunction because methotrexate is actually an immunosuppressant too, no? So some complications of methotrexate. So some buzzwords, risk factors. Favorite din nila yung mga risk factors na for risk factor for preeclampsia or risk factor for ectopic pregnancy. So common yun na tinatanong din. So if kaya, then please be familiar with them. So which of the following, can anyone mention in the chat box, which of the following would be the highest risk factor, strongest risk factor for ectopic pregnancy? Yes, it's prior ectopic pregnancy. Very good. 99% of ectopic pregnancy implants in the fallopian tube, obviously, in the ampulla. So next, medyo mahaba, no? So ang strategy ko nung nagbo-boards ako, pag mahaba yung question, tingin muna ako sa question, sa dulo. Nasa dulo yung palagi. Which of the following is the next step in the management of this patient? Syempre, hindi siya helpful, di ba? So, kailangan niyo basahin ulit yung tanong. So anyway, so a 39-year-old G2P1, 39 weeks AOG, may BP daw siya na 150/100. So obviously it's elevated. Baseline blood pressures were normal. Heart rate is reactive. So alam niyo okay si baby. CTG shows irregular uterine contractions. So the patient's cervix is 3 centimeters dilated. Repeat blood pressure is still elevated. And while being evaluated in the triage, she is noted to have tonic-clonic seizures in the presence of an elevated BP. So anong sakit to? Sorry kung medyo maingay po. Nasa lobby ako ng ospital. Pero rinig naman ako, Doc.
Yes, Doc, dinig naman po. Hindi naman masyado maingay. Carry lang.
Okay, so most of you got it correct. Now 63% of you got the correct answer. It's to give a loading dose of magnesium sulfate. Yeah. So what's the disease again being described in this situation? It's eclampsia, yes. Kasi meron ka ng tonic-clonic seizures, no? So kailan nga, at what period would usually seizures occur during eclampsia? Antepartum, during labor, or postpartum? It's during labor, yes, very good. So hindi letter A. At tandaan niyo yung question ay, which of the following is the next step? So hindi naman tayo magsisiyas kaagad, Brad, kasi hindi pa naman siya emergent cesarean section kasi okay pa naman si baby, no? And administer low dose aspirin orally. This is actually a preventive therapy for preeclampsia, no? Low dose aspirin. So hindi natin binibigyan pag eclampsia, pag meron ka ng eclamptic seizures. Start a labetalol drip to lower the blood pressure. Yeah, I mean, you can start lowering the blood pressure, but then again, the question asks for the load. The question asks for the next best step. So, what does magnesium sulfate do during eclampsia? Bakit important magbigay ng loading dose ng magnesium sulfate? So it's been shown that magnesium sulfate decreases the next episode of seizures, and also it's for neuroprotection, no, of the baby. So a favorite din to, no, yung topic, yung preeclampsia, hypertensive disorders in pregnancy. So remember lang yung cutoffs niyo for hypertensive disorders, 20 weeks, age of gestation and beyond, and it's going to be either gestational hypertension or preeclampsia. And kapag meron kang less than 20 weeks age of gestation, na elevated na yung blood pressure mo, then it's already considered chronic hypertension. So, bakit nga 20 weeks yung cutoff? I mean, anong factor, anong organ yung nade-develop, fully developed by 20 weeks? It is the placenta. So, yung placenta natin, fully formed na siya during the 20 weeks age of gestation. So, yun yung parang isa sa magiging important factors ninyo. Why would you have preeclampsia and pregnancy? Okay? So, remember lang yung differences, no? Gestational hypertension, PE without severe, and PE with severe features. Important yung severe features ng daan, no? So, meron ako mnemonic for preeclampsia. It's bad triple. Actually, galing to kay Ma'am Shane. Oh. Sorry. So, bad triple, no? So, it's elevated BP. A would be, no, it's nothing. D would be none. Sorry. Bad triple. So, it's BP triple. So, T is going to be thrombocytopenia. And R is renal disease. Tandaan ninyo, no, kapag preeclamptic yung patient, dapat kung magko-consider kayo ng renal feature as a severe feature of your preeclampsia, dapat it should be in the absence of any other organic kidney disease, no? So I would be P would be P is pulmonary edema. So I is intracranial disturbances. So intracranial disturbances meaning meron kang cerebral, no, or visual symptoms. It's usually headache or visual disturbances like scotoma. Scotoma yung pinaka common na visual disturbance in preeclampsia with severe features. L is for liver elevation, LFT elevation. Again, LFT elevation, kailangan meron kang absence of any other organic liver disease. So, bakit yan nagkakaroon ng abdominal pain? Kapag meron kang, minsan kinocall nila as a severe feature. Bakit nga nagkakaroon ng abdominal pain? So, usually kasi kapag nagkakaroon ka ng hepatic necrosis, no? Nasa-stretch na yung Gleason capsule, no? So, yun yung nagdudulot ng abdominal pain kapag meron kang preeclampsia. Finally, E. So, it's bad triple, no? So, remember yung important na cutoffs for your BPs, huwag kayong malilito doon, 140 saka 160. Okay, so again, risk factors for preeclampsia, important din tatandaan niyo to kasi yung mga may lumalabas din paminsan-minsan na risk factors for preeclampsia. So interestingly, smoking is protective of preeclampsia, di ba? So primarily disease related. So ibig sabihin meron ka ng previous na inflammation, low level of inflammation, such as chronic hypertension, or meron kang APAS. So, lahat yun pwedeng maging risk factor for preeclampsia. Immunogenic related, so usually, ito yung introduction of a new antigen, either paternal, no? Kaya meron kang new paternity here. Kaya meron kang new paternity, and dahil sa fetus mismo, no? So, may risk factor for preeclampsia kapag kaka-baby niya pa lang. So, also previous preeclampsia kasi meron ka ng presence of previous antigens, no? Multiple gestation kasi mas marami kang babies, and abnormal placentation. So, family history, of course. Alam mo ba sa atin ito nung isa sa mga boards dati, no? Sa tandaan niyo, pag meron kang female relatives na may preeclampsia, it's a risk factor for preeclampsia. Also important to remember yung magnesium sulfate, no? So, yung dose ninyo would be 4.8 to 8.4. Yun yung therapeutic dose range ninyo of magnesium sulfate action. So, ano ang antidote natin for magnesium sulfate toxicity? Calcium gluconate, yes, very good. Ano yung common na, ano yung mabilis na clinical test para malaman mo kung meron ka ng magnesium sulfate toxicity? Yes, DTRs, no? So yung mga knee-jerk reflex, very good. So simple laboratory test, it's gonna be urine protein, percentage of neonatal death that occurs with HELLP syndrome, it's 20-25%. So mahilig din sila sa mga percentages. So wag kayong ma-discourage kapag may mga lumabas na mga ganyan. Kasi common yan sa OB, no? Ilang percent yung infertility, ilang percent yung magle-labor, ilang percent yung ganito ganyan. So maraming ganun sa OB. Serum concentration, again, it's 4.8 to 8.4. Manner of confirming elevated blood pressure during pregnancy. So, of course, obviously, should be seated when blood pressure is taken to occasions 4 to 6 hours apart. So, may mga simpleng tanong din naman na lumalabas sa boards tulad nito. So, kahit pa paano, +1 point din yung para sa inyo. So, anti-hypertensive drug used to control premature labor, it's going to be nifedipine. Nifedipine is a calcium channel blocker. Next, without intervention, how many % of patients experiencing PROM will go into delivery within 48 hours from the initial onset?
All ended, Doc.
So the correct answer here is yes. Yes, very good. It's going to be 75%. No? Most of you got it correct. So, tinanong sa boards dati kung ano yung definition ng PROM saka ng PPROM. So, again, PROM, it's rupture of membranes before 37 weeks age of gestation. PPROM, it's gonna premature rupture of membranes. It's the rupture of membranes before onset of labor. So, meron kang preterm, premature ROM, no? It's a combination of the two, obviously. And prolonged rupture of membranes, it's going to be 18 hours. No? So prolonged rupture of membranes is a risk factor for developing what disease? It's chorioamnionitis. No? Yes, chorioamnionitis. So without intervention, approximately 50% of the patients in 24 hours and 75% of patients within 48 hours. So, meron tayong iba't ibang tests for rupture of membranes. This is pooling of vaginal fluid, amniotic fluid in the posterior fornix of your vagina. Ito ay yung nitrogen test, no? So, nag-change yung color ng paper kapag nahaluan siya ng amniotic fluid. So, amnisure din, no? What's amnisure again? Anong tinetest niya na compound? Ay, na protein, rather. Alpha. Yes, it's alpha microglobulin 1, no? So, this one is what we call what pattern is this, no? Kapag meron kang, nakita ka na, yes, it's ferning, no? Pag nakita mo yung vaginal secretions mo, tapos nilagay mo sila sa slide, nag-spread ka sa microscope, you will see ferning, no? Versus beading, no? Kapag yun yung opposite ng ferning. This one shows you an injection of dye within the amniotic sac, and then meron kang tampons dulo, no, sa vaginal canal mo. So kapag yung dye, yung indigo carmine na dye, kapag tumagos siya papunta doon sa from the amniotic sac papunta doon sa tampon na nasa vagina, then it's positive for rupture of uterus. Next, a 45-year-old comes to see you with a complaint of 14 months of regular bleeding. So she previously had regular monthly menses, but they have become totally unpredictable. No? So sometimes she will bleed for 2 to 3 weeks on and off, tapos 2 months ulit na walang cycle. Tapos PE daw normal, cervical cytology normal, no other tests are abnormal. No flashes, night sweats, or vaginal dryness. Pelvic ultrasound is normal. EM biopsy shows proliferative EM without hyperplasia or malignancy. So how would you properly define her bleeding pattern? Okay. So ang tanong ay, would you properly define the bleeding pattern? No? So, tandaan ninyo na yung metrorrhagia and menometrorrhagia, these are both definitions before na hindi na usually ginagamit. No? So, kapag meron tayong case of abnormal uterine bleeding, then meron na tayong classification, di ba? Ano nga yung classification natin of abnormal uterine bleeding? Anong tawag doon? Yung palm coin, yes, yung palm coin classification, no? So, it would be more properly defined kapag ni-refer natin yung case na to of an abnormal uterine bleeding as an AUB dash and any of those palm coin notations, no? So, AUB, so in that sense, CND out na yan, no? So, AUBN would be the proper answer. Bakit hindi AUBU? Kasi wala kang abnormalities within the uterus. No? So AUB, again, ito yung patterns of abnormal uterine bleeding, but diagnosis is different. It's AUB dash anything else. PAMCO. So please remember yung notations natin for palm coin. May mga tinatanong sila dyan palagi, no? Paminsan-minsan. So next, a 27-year-old G0 presents your clinic with regular menses, 4 to 5 menstrual cycles per year for the past year, worsening acne, meron siyang makakapal na buhok sa upper lip, chin, and abdomen. PE is remarkable only for hair and acne, she described, as well as obesity. So you perform a bedside ultrasound, meron daw siyang small follicular cysts on bilateral ovaries. Correctly diagnose her with PCOS. So again, PCOS, imagine yung haba ng question, tapos yung tanong ay nasa dulo. In PCOS, patients are likely to have which of the following physiologic changes? Okay. So the answer here is actually letter B. Letter B, no? So increased frequency of GnRH pulses. So again sa PCOS, no? Yung LH secretion natin is elevated. Androgen is elevated, obviously. So yung D out na kagad, no? Tapos meron tayong yung increase in androgen ninyo nag-inhibit siya ng negative feedback on hypothalamic GnRH pulse, no? So ibig sabihin meron kang tonic na GnRH pulses. So that's why letter B is yung answer. And so kapag meron kang increase in GnRH pulses, then your FSH will decrease. And also, in PCOS also, your estrogen is usually high. So remember in PCOS, ang usually na lumalabas ay also yung Rotterdam criteria, no? So any two of the following: anovulation or hyperandrogenism, and PCOS and polycystic ovaries on ultrasound. Remember, polycystic ovaries, it's a diagnostic result, no? It's not the disease. Polycystic ovarian syndrome is the disease. So obesity is also an important manifestation of PCOS kasi increase in your peripheral peripheral fat would actually increase your estrogen levels. Okay. Next, age group wherein evaluation for infertility should be initiated after failure to conceive within 6 months of unprotected intercourse. So very good. Most of you got the correct answer. It's letter D, no? More than 35 years. So recently for the previous boards, marami silang tanong regarding infertility and marami infertility, PCOS, and contraception. Marami silang tanong regarding those. So kung may aaralin kayo na high yield topics, that would be those three. No? So infertility, again, it's the failure of a couple to conceive after 12 months of unprotected sexual intercourse. So assuming na regular yung unprotected sexual intercourse, no? And important lang na tandaan niyo here would be kapag more than 35 na kayo with no pregnancy after 6 months, then you should investigate for the cause of infertility. 9. 45-year-old G1P1 presents for her routine annual examination. She's a healthy smoker. Well, sorry, it should not be a healthy smoker. She is a smoker who has no medical problems. Surgical history is significant for a CS delivery with BTL. No, perform a Pap smear showing HSIL. Undergoes colposcopy, which is inadequate. What is the next step in management? Okay. So very good. Bone biopsy yung next na dapat ninyong gawin. Kasi kapag nag-colposcopy, keyword doon, nag-colposcopy na daw, no? Tapos ang sabi, inadequate daw. So kapag hindi niyo na-visualize ang goal ng colposcopy ay ma-visualize ang transformation zone, no? Ang squamocolumnar junction. So kapag hindi niyo nakita yon, then it would be prudent to immediately go for biopsy, no? So for cervical cancer, I think lumalabas yung mga HPV types and yung Pap smear results, anong management niyo for Pap smear results, and also staging for cervical cancer. So kung may aaralin, kung may iba-bank on kayo na cancer na lalabas for OBGYN, palagi yan, cervical cancer. There will be usually one question for ovarian cancer, which is mostly staging. For endometrial cancer, it's going to be one item also, but it's usually risk factors for endometrial cancer. Pero pag cervical cancer ang usapan, lahat yan, no? So again, which of the following human papillomaviruses are high risk? (16 and 18), no? Okay, so those are your high risk na HPV subtypes, serotypes. And again, kung yung tatandaan niyo, usually pag secondary prevention, yung kung kailan nagsa-start, no? Kung kailan nagsa-start, and kung every when yung frequency ng screening. So remember that for young populations, we do not screen usually, no? Kasi mababa yung risk nila of infecting, well, one, mababa yung risk of infecting HPV, and also mabilis within 2 years usually, no, kinakaya ng katawan na maalis yung HPV from the system. So abnormal pap smear results would be management of cytological abnormalities. Ang important dito tatandaan ay colposcopy. Ito yung parang cut-off. Tinatandaan ko itong table na ito. Palagi kong kina-cut off yun na anything after ASCH. A typical squamous cells, no? Tapos after nyan, palagi na siyang may colposcopy. So H-cell ninyo, may colposcopy. AGC and AEC ninyo, may colposcopy. Pero ang difference ay, yung H-cell ninyo, it's high, H-cell. Sorry. Yung H-cell ninyo is essentially CIN-free, no? It's cervical intraepithelial neoplasia free. So ibig sabihin, meron na kayong almost invasion, no? So kailangan niyo na ma-visualize at makita kung nag-go beyond na ba siya doon sa normal boundaries ng neoplasia ninyo. Kasi kapag nag-go beyond na siya sa boundaries, then automatically cervical cancer niyan. Carcinoma in situ ng tawag doon. Okay? So H-cell colposcopy, AGC, AEC, kailangan niyo palagi mag-endometrial sampling kasi although rare, no, meron kayong, kapag nakakita kasi kayo ng endometrial cancer, at pag nakakita kayo ng endometrial cells or glandular cells within your pap smear, then baka kasi meron kang EM na neoplasia or malignancy. Kaya tayo nagkakaroon ng endometrial sampling also. Pag ASCOS, remember lang na it's reflex testing, no? Reflex testing is HPV testing, no? And for LSIL, usually you repeat the cytology after 12 months, or you can do also HPV testing. So again, 12 months, yung ginagawa natin na repeat cytology kasi within 2 years, no, usually nasa-shed off ng katawan yung HPV. So we've gone through those pap smear results and rationales. So cervical cancer staging. So ito yung important na matandaan ninyo. Remember, pag stage 1 microscopic, no? Kapag stage 1A microscopic siya, kapag stage 1B visible na siya. So ganoon siya tinatandaan. Kapag stage 2A, wala ka pang parametrial invasion. Kapag 2B, meron kang parametrial invasion. So ganun ka tinatandaan yung stage 2. Tapos kapag stage 3 naman, no, ito medyo tricky na to, pero it's gonna be lower 1/3 of your vagina, but no extension to your pelvic wall. Pero pag 3B ka na, meron ka na extension sa pelvic wall and or hydronephrosis or non-functioning kidney. So ibig sabihin yan, affected kasi yung kidneys niyo near the pelvic walls yan. No? So kapag natamaan niyo yan, stage 3 na yun. No? So lastly, obviously, pag 4A adjacent organs, kapag 4B, meron ka ng spread to distant organs such as your lungs. Last, a 36-year-old woman presents to your office to discuss contraception. Medical history is significant for hypertension, well controlled, and seizure disorder. But her last seizure was 12 years ago. Currently, no anti-epileptic medications. She also reports stress-related headaches, relieved with OTCs, no? Never had surgery. She is divorced, smokes 1 pack of cigarettes per day, and has 3 to 4 alcoholic drinks per week. Nag-OCPs na daw siya dati, and she wants to restart them because they help with her cramps. So which of the following would contraindicate the use of OCs in this patient? Yes, very good. So most of you got it correct. So the correct answer for this item is smoker more than 35 years old. So lumabas sa boards dati, contraindications for COC use. Also lumalabas din yung IUD ilang taon, kung aling IUD yung matagal, yung 10 years and 5 years.
Alright, mukhang na-disconnect si Dr. Vidal. Alright, kasi nasa ano siya, nasa States siya ngayon. Pero at least na-discuss na niya yung 10 wait lang. Dr. Vidal is here again. Doc Vidal, are you here? Are you back? Okay. Wala si Dr. Vidal. We'll try to wait for him to come back. So, pero mga bees, natapos naman niya, no? Nairaos niya ang 10 questions for you guys. So, if may mga questions, please message them to us na lang para ma-forward namin kay Dr. Vidal. Pero antayin natin siya makabalik kung wala siya.
Clarify ko lang parang medyo alanganin ako dun sa isang yung number 6. Asa na si Doc? Nasa na si Doc Mavi? Andito na ba?
Mavi, are you here?
Tama ba ako ng pagkakaintindi sa question number 6? Perimenopausal to, no?
Wait lang.
Clarify lang natin, baka nalilito sila. Okay. Perimenopausal kasi ito mga B. Kung 45-year-old na 14 months, doon pa lang siya may irregular bleeding, mukhang perimenopausal, no? Pag perimenopause, nag-argue pa rin sila kung saan siya ilalagay. Sa AUB, pero most probably AUBO, ovulatory. Kasi syempre yung mga follicles natin, di ba, hindi na marami ka ng anovulatory cycles. Kaya kung sa perimenopause, AUBO siya. Kung tama yung pagkakaintindi ko, haba kasi ng question, AUBO. Okay, ang not otherwise classified are the mga infections, mga
Yes,
trauma.
mga trauma. Usually trauma yung source, no? But for the
Ayun.
question, hello?
Yes, go.
Pero for the I think that I maybe I did not provide yung correct na answer po. Pero if you were to choose there, I mean, wala naman obviously AUBU. So, and menorrhagia and menometrorrhagia are old definitions na. So, I think I would go with AUBN. But the proper answer for that question would be, yes, AUBO po.
Okay, yung mga AUB classifications natin, no, it goes, ang ano niya talaga, it's for mga reproductive age women. Kasi automatic pag menopause, tas nag-bleed, ang unang iisipin mo is you have to rule out malignancy first before considering all the other causes. So yung palm coin classification is basically for reproductive age women. Kaya sila nagkakagulo with perimenopause, kung ovulatory ba yon or endometrial ang gagawin nila. Pero for this question, I think it's AUBO kasi ovulatory yung mga cycles. Yon lang naman. Thank you, Doc Mavi.
Thank you, Doc Mavi. We only have one question lang, Doc. Question number 3. Not po ba daw yung nakalagay sa question or iba? Ang na-flash kasi natin kanina for the question is not. But parang naiba daw po ata during the discussion. Question number 3, Doc.
Yes? Ito po ba?
Number 3, Doc. Yan. Ang nakalagay sa questions, Doc, na PowerPoint is not.
Oh, okay. Would not improve methotrexate success. So if not would be the question, then everything else, BCD, would not improve methotrexate success. So the only correct one there would be letter A. Yeah.
Okay na po. Alright, sana clear up natin yung question. Ayan. Thank you very much, Dr. Vidal. And thank you din sa ating mga students. I'm sure, na sila, maaga rin pa sila tomorrow for our patho intro. So we'll see you guys tomorrow for our synchronous session tomorrow. Alright, so good night mga bees. Thank you, Dr. Vidal. Thank you, Doc Nina. Maraming salamat po. Good night, everyone, and happy aral. See you tomorrow.